welcome to the public hearing for the inquiry into budget estimates 2022. Before I commence, I'd like to acknowledge the Gadigal people who are the traditional custodians of the land. I'd like to pay my respects to elders past, present and emerging of the Eora Nation and extend that respect to others Aboriginals present and joining us over the internet over the course of the day. I welcome Minister, Mr Hazzard, and accompanying officials to the hearing. Today the committee will examine the proposed expenditure for the portfolio of health and medical research. Before I commence, I'd like to make some brief comments about the procedures for today's hearing. Today's proceedings are being broadcast live via the Parliament's website, and a transcript will be placed on the committee's website once it becomes available. In accordance with the broadcasting guidelines, media representatives are reminded that they must take responsibility for what they publish about the committee's proceedings. All witnesses in budget estimates have a right to procedural fairness according to the Procedural Fairness Resolution adopted by the House in 2018. There may be some questions that a witness could only answer if they had more time or with certain documents to hand. In these circumstances, witnesses are advised that they can take a question on notice and provide an answer within 21 days. If witnesses wish to hand up documents, they should do so through the committee staff. Minister, I remind you and the officers accompany you that you are free to pass notes and refer directly to your advisors seated at the table behind you. In terms of audibility of the hearing today, we have witnesses in person and via video conference. Can I ask committee members to clearly identify, who questions are being directed to, and could I ask everyone appearing remotely to please state their name when they are speaking. And that will assist in the preparation of Hansard so they can clearly understand who's speaking in terms of questions and answers. Could I also ask everyone please to mute their microphones when they are not speaking. Finally, could everyone please turn their mobile phones to silent for the duration of the hearing. All witnesses must be sworn prior to giving evidence. Minister, I remind you that you do not need to be sworn, as you've already sworn an oath to your office as a Member of Parliament. For all other witnesses, I'll ask you in turn to state your full name, your position, title and agency, swear either an oath or affirmation, whichever you prefer, the words of which should have been provided to you already. If for some reason you haven't got them or they're not at hand, please let us know and we'll provide them to you. So in proceeding now, I'll deal with the swearing and affirmation of the witnesses in the room first. So if we could start with Ms Koff and move across from my left to right, and then we'll move through those who are participating remotely. So thank you, Ms Koff.
Thank you, Mr Donnelly. Elizabeth Koff, Secretary of New South Wales Health. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you very much. Please.
Good morning. My name is Susan Pearce. I'm a Deputy Secretary, New South Wales Health. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you very much. Now, I've got a list of the participants who are participating remotely today, so I'll go down that list in this order and get each one of you to please either swear or affirm. So, starting with Dr Lyons.
Nigel Lyons, I'm Deputy Secretary, Strategy and Planning, New South Wales Health. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you, Dr Lyons. Mr Menz. Mr Menz.
It's a good start.
I'm Gregory Menz, Deputy Secretary for People, Culture and Governance in the Ministry of Health. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you, Mr Menz. Ms Dawson.
Good morning.
Good morning.
Susan Dawson. I'm a Commissioner for the New South Wales Healthcare Complaints Commission. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you, Ms Dawson. Ms Walk.
Good morning.
Good morning.
I'm Rebecca Sharon Walk. I'm the Chief Executive of Health Infrastructure. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth.
Clear answer is just to have women in charge of everything.
Thank you. Welcome. Mr McLaughlin.
Good morning, I'm Scott McLaughlin, the Chief Executive of Western New South Wales Local Health District. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you, Mr McLaughlin. Mr De Lorenzo.
Good morning. Michael De Lorenzo, Chief Executive of 100 Million Local Health District. I swear the evidence now about to be given by me shall be the truth, whole truth, nothing but the truth, so help me God.
Thank you, Mr De Lorenzo. And Mr Loy.
Good morning, Graham Loy, Chief Executive for Western Sydney Local Health District. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you, Mr Loy. And for completeness, I should just note that Dr Chant will be joining us later today to provide evidence, and we're very grateful for her being available. And I understand she'll be in person from 2 p.m. this afternoon, so we'll deal with her.
Mr Chairman, can I just indicate on that front that that is the hope?
The hope, okay,
The
yes.
hope, because the Supreme Court, a subpoena of the Supreme Court of New South Wales was issued to her, and so she is required to be in court today.
Of course.
We're assuming that they might deal with the matter sufficiently with the evidence this morning, and hopeful that she'll be here this afternoon. But it really is, unfortunately, just a clash of events. But I'm sure that if there are any questions that Dr Chant is needed to answer and she's not here, then of course we can take those on notice and deal with them later.
Thank you, Minister, for that update. I appreciate that very much. That makes things clear for us. Appreciate that. Now, our hearing allocation times today are as follows. So we've got things underway, obviously, with the first part, the formalities. Will take us through to 12:45 p.m. There's going to be a break between 11 and 11:15. That's a scheduled break, but a break that will be just that tight 15 minutes, and people will be able to sort of deal with matters during that 15 minutes if they need to do so. We then commence what is effectively the lunch break at 12:45 through to 2 p.m. So that obviously is the hearing will be set aside during that time. We then come back at 2 o'clock, go through till 5:15. We expect or thereabouts, and there'll be a break, an informal break between 3:30 and 3:45. So that's what we've got scheduled for today. Now, questions in terms of how in which they'll proceed in the normal course, it'll be opposition and crossbench, and there is a period of time of, in fact, 15 minutes allocated at the end for government members to, if they wish to do so, ask any questions. Now, there's no provision for opening statements, so we'll get things underway and we'll commence with the opposition.
Thank you, Mr. Chair, and thank you everyone for attending today. Thank you, Minister. And before I commence, I'd just like to convey a message to Elizabeth Koff. Can you please convey to health staff, health workers, health professionals across the state that any questions today will not be a criticism of them and their work during the COVID period, but I just want to say that at the offset. So thank you very much, and thanks for what you do and
Thank you, Mr.
what all
Segal.
the health officials are doing and health workers.
Thank you.
On that note, it'll come as no surprise that the first questions we'll ask will be in relation to COVID. Minister, now the whole state is now, actually, what is the current vaccination rate at the moment in New South Wales statewide?
You're talking first dose or second dose?
Second dose. Second dose.
Second dose, it's about 86.
88.7% as of yesterday, Mr. Scott.
88.7. How does that relate? How does that compare to comparable international jurisdictions around the world?
The rate needs to be considered on a whole of population basis, and we can provide that number to you. The important factor with regard to comparing to rates across the world is at the time of opening what the whole of population vaccination rate was. New South Wales, the last number I had, but I will get an updated figure for you, was we were at around 72% on a whole of population basis. That compares quite well to jurisdictions around the world.
So when you say 72%, that includes children, minors, that
That's
kind of...
correct,
the
but
whole
I will
thing?
get an updated figure for you.
And what's the percentage of first doses in New South Wales?
93.7% as at yesterday in the adult population.
93.7. Now, it's the old adage that, what have you done for us lately? Now, people are now moving to questions about booster shots. So, how will the booster shots work? Will it be 1 and 2, or is it just simply one shot? Can you give a bit of an explanation? And then I'll ask a few questions about boosters.
There's no, look, a few weeks ago, I think there was a hope that the boost, on the advice from the federal government and from Dr. Paul Kelly, there was a hope that the booster shot might have been similar to other vaccination programs. It could have been lifelong. But at the moment, my understanding is there's a lack of certainty about that. And so the commitment is to undertake the booster program. And obviously there'll be further advice coming in due course as to whether or not it'll be necessary to have those, whether it's annually or whatever it be. It's simply, the jury is out on that at the moment, but the safest course for us all, and for anybody listening today to say, obviously whether it was AstraZeneca or whether it was Pfizer, there's some evidence that the necessary immunological response drops off after about 6 months.
Yep.
So it'd be a very good idea for us all to go and get the booster as soon as we're eligible. The eligibility at the moment is about 6 months, so 6 months after the second shot.
6 months.
Six months after your second vaccination. So it'd be preferable to book in. As to the arrangements for that, I must say from New South Wales's point of view, and I think from talking to all the other Labor and Liberal ministers around the country, state ministers and territory ministers, we'd all prefer that it be normalised in the sense of what used to happen with vaccinations, so primarily be GPs and or pharmacists delivering the vaccinations. But for the time being, having in mind that this is coming off the back of a 1 in 100 year pandemic, the New South Wales government has determined that it will continue to provide vaccinations also through the boosters through some of our mass vaccination hubs and other facilities across the state. So people can book in now if they're past their 6 month period and do it. I'm certainly looking forward to doing mine. I think mine cuts in fairly soon. So.
Now, will the mass vaccination hubs remain open, or will they...
Well, that's what I just said, that most of the mass vaccination hubs will... well, we've got obviously the big ones like the one at Sydney Olympic Park. And we've got the one at... I was going to say thank you for your contribution.
Original,
The original one, and the other ones at Belmont.
Yep.
And of course there's Kudos, but Kudos is closing because it'll close in the next few weeks. Actually, Susan will be able to tell us exactly, but that one was only available because it's obviously for entertainment as well, and as entertainment opens up, which we've been working towards, they want to use it, so that's fine. But a lot of the other facilities across the state-run facilities will actually continue to operate. So hopefully though, I would envisage that by sometime next year, the majority of the delivery of the booster vaccines should be done, hopefully, through GPs and pharmacists, but we'll have our state facilities still available just in case for the time being.
Ms. Husas?
Thanks, Minister. I just wanted to ask you about then, have you had discussions, and I understand that this would be also for Minister Dominello, but have you had discussions about how those boosters will then integrate with the vaccination passport system?
Well, any of those, what happens is when you have your shot, if you have been vaccinated,
yes.
You know that you get, it is available then on your Medicare facility, so you can get your effectively evidence of your vaccination. whenever you get vaccinated, it goes to the federal government anyway through a process that all states and territories follow.
Yeah, through the immunisation statement, the national immunisation statement. That's right. But what I'm interested in is how will the booster then be integrated into that and then into...
Well, it's just the same. It just goes on there. And the work that customer service is doing will just, I'm sure, eventually get there on that. But I haven't spoken specifically about that. Susan Pearce, Deputy Secretary Pearce wants to say something. So, yeah.
Just with respect to the booster, if I can understand the point of your question is, will it contribute toward being fully vaccinated? Is that what is
the next stage? Like, obviously, at the moment, we need to show that we're double vaccinated to get access to certain places, or as we did this morning to come into Parliament. Are you working on how you will notify or how people will be able to notify venues if they have received their booster?
At the present time, the advice from the Commonwealth Government is that the primary 2 doses is what counts as being fully vaccinated. Yep. So the booster dose itself is a booster. If you've already had the primary doses, then you are fully vaccinated. And if at a point that changes and you're required to have the 3rd dose, to be considered fully vaccinated, then that would obviously be addressed in the same way that we addressed the issue in the first instance.
I didn't understand, Courtney, before what you're actually getting at, but yeah, at this stage, there has been no decision taken to say you must have the booster.
That was going to be my question.
Yeah,
so,
there's nothing on that front. But I mean, obviously, it's sensible to do it because. So
if you refuse at this stage right now, if you refuse to get the booster, see, I'm ready for the booster in December. So if I don't get the booster then, do I lapse into unvaccinated?
No. Under the current federal guidelines, you're still vaccinated. But I mean, that's what I was saying before. Oh. The one thing I've learned, and this is I've said a few times now, is never say never. And the federal government and obviously the health people, the research people are looking at just what the drop-off is in terms of the immunity.
But Minister, can I ask the question then?
Sure.
So as of October the 25th, I think there was 2,348 staff in health that were unvaccinated, about 1.5%. Now, so if we get to the stage where you meet the criteria of the 3rd booster, the booster, will you be requiring health department staff to get the booster?
We've taken no decision on that at this point.
But you must have people who are already in that, because I know people who, in fact, are getting ready to get their booster now.
Yeah, well, there's an enthusiasm, and we want to make sure there's enthusiasm. We haven't made a decision on that aspect at this point. The decision that was taken was obviously around the federal government guidelines of what was required to keep the community safe and to keep patients safe. But I don't know whether either one of the senior executive on it, but as far as I'm concerned, that decision has not been taken as yet.
With respect to the health staff, Mr. Secord, there is a great deal of enthusiasm amongst our health professionals for the booster dose. I can tell you that since Friday we've administered over 10,000 booster doses just in the New South Wales health clinics.
Oh, really?
So the take-up has been very high so far, and particularly with the announcement over the weekend as to we brought you'll note that the Commonwealth Government announced boosters commencing from next Monday, the 8th of November. We brought that forward to the 1st of November as a sign of our eagerness to encourage our community to receive that booster dose if you're 18 years and above. And in addition to that, yesterday we sent out 71,000 SMS messages to people within our system who had received their 1st and 2nd dose with New South Wales health clinics. Obviously some months ago now, to advise them that now was the time to come and book in for your booster dose.
So do you, so I know countries like Israel, if you don't have if you don't have the booster in Israel, then you fall into the category of being unvaccinated again.
We haven't.
It's a matter for the Commonwealth Government.
We haven't.
So do you have views on that, Brad, which you're leaning towards? Do you think Minister. Oh, sorry, Minister, I didn't mean to say
That's all right. I'll go with Brad. That's fine. Well, personally, I'm very supportive of the booster shot being taken, but I haven't formed an absolute view at this point as to whether or not we should be mandating that. I mean, in a sense, we haven't mandated it for anybody except workers at the front line of particularly vulnerable business enterprises, so education, health and so on. You can actually, as silly as I think it is, you can actually choose not to be vaccinated. I would expect that if the drop-off is substantial, that the TGA and/or ATAGI would probably or give some advice to the federal government in due course on boosters being necessary. But look, it's too early to say for sure.
Ms. Pearce, so
That's purely instinct from the last 2 years of dealing with COVID. But
now, and in response to questions on notice, came back on October the 25th that there are 2,348 people who are unvaccinated in New South Wales Health. So what is New South Wales Health doing to target that pocket? Now, I know that there'd be people in that category who would be immune compromised, and also women recovering from chemotherapy, breast cancer. So I do understand that there would be a small pocket that can't be vaccinated for health reasons, but there must be a small, that 1.5%. So what is it now, and what are you guys doing to...
My colleague, Mr. Minns, can address that question, Mr. Secord.
Thank you. Mr. Minns, please. Did you hear my question?
where is he?
Mr. Minns?
Yes, I did. Yes, I'm here. Phil Minns speaking. Look, perhaps if I give you a bit of a recap on our status with respect to vaccination. The workforce that we've considered possibly needing vaccination is a very large number. It's 176,964, and it's a very large number because it represents everyone who's currently active on our Stafflink payroll system.
Okay.
And that can include people who are on long leave. It can include people who are casual but have not worked for us recently. It can include agency staff who are either working with us or haven't worked with us recently. So it's an overstatement of our active workforce. Our active workforce, when we did the annual census at the end of June 2021, was just over 156,000. So if you take that over, for abundance of caution number, 175,000, 97+% of those people are vaccinated. And it's therefore an overstatement of our active workforce that are not yet vaccinated. The only way to get close to that number is to do the bottom-up analysis, which has occurred in all of the health organisations and local health districts and networks. And so that has produced a potential population of about 2,100 where we still don't have a record of their vaccination. And we're in the process of working with each of those individuals directly one-on-one to try and understand their context and circumstances. We continue to encourage vaccination. We see if we can provide information to people that they might require to reach a decision.
So
but ultimately, that number of people, we expect it will come down a little bit, but it's in that order.
So Mr. Minns, 2,100. Thank you. Ms. Husas has a question.
Thanks very much, Minister. On Tuesday in budget estimates, we heard that the Education Department was hiring investigators to enforce vaccination compliance. Is New South Wales Health conducting any investigations into its own staff on their vaccination status or to verify that?
Not that I'm aware of. We've just been working with the staff in a collaborative way to try and make sure people understand the benefit of being vaccinated.
And all of those, do you have any or perhaps Mr. Minns, you might be able to tell us, do you have any verification process? If someone says that they're vaccinated, is that the end of the story, or do you then go through a verification process?
At the local employment level, there is a process to identify that people can demonstrate their vaccination. So it's usually just done by the local manager where the person works.
And you haven't hired any new staff or external consultants to investigate these issues?
No.
Not that I'm aware of.
Thanks very much.
Been no discussions on that basis. If there has been with the Minister, I don't think that was necessary at all. Yeah.
Ms. Husas? Oh, okay. Minister, can I take you a bit broader on COVID? So in the middle of last year, your government announced that it was going to commit an extra $800 million to the health budget to increase ICU capacity in that. So what has been the expenditure on COVID in New South Wales since the pandemic.
I think we actually ended up putting more than 1.1 billion from memory. I'll get the exact figures for you in due course, but it's been a lot of extra money, obviously, and it wasn't just about ICU. It was about all that went on. Obviously,
Sorry.
there wasn't just ICU, Mr. Secord. There's factors like the extra payment for getting staff to do the vaccinations, bringing more people on to do it, a whole lot of things. About 1.1 billion is the recollection. If it turns out to be wrong, then I'll get some details to you in due course.
Ms. Coff?
Yes, it is one. I can confirm, Minister, it is
there you go.
1.1 billion. 340 million was spent to fund personal protective equipment, PPE, which was absolutely integral to managing the outbreak. 261 million for COVID-19 vaccination distribution, the establishment of the mass vaccination centres and the administration of those was quite a logistics effort. 200 million for pop-up clinics, testing and contact tracing. As you're aware, we had a rapid response to outbreaks and we could turn around and establish testing clinics, pop-up clinics. We did it at Crossroads. We did it at a variety of locations. Hotel quarantine was 145 million from our perspective with medical assistance and support. We were keen to keep surgery going. That was one of the critical issues. So we did allocate 80 million for additional elective surgery. And something that people don't expect often is the increase in cleaning costs associated with the facilities that COVID presented to us. So 30 million for enhanced cleaning within the health facilities. So the funding was absolutely essential for us delivering the results that we have achieved.
Now, could I add to that I mean, that's the broad figures, but it's really hard to compartmentalise some of the figures because obviously health's a massive machine. It is. And for example, what was the cost of us assisting? At one stage we had, how many was it that went to Victoria? About 50, 60, 70 staff? We had probably the best part of 100 staff, I think, that went down at various stages to Victoria, which obviously stayed on taxpayers' budgets here. Right now we have retrieval teams. You could go out, I have a photo on my phone at the moment of a New South Wales ambulance sitting outside the Alfred in Melbourne. We have staff, we have ambulances, we have facilities. We're still picking up all those costs because we just figure that it's our role as one of the state governments that lead the country to actually back in everybody else too. So the costs have been distributed. It's not precise, but overall about 1.1 billion.
Thank you, Minister. I'm just mindful my time's coming to an end. Now,
never say it quite like that.
Traditionally, the Christmas period was when surgeries drop off, activities in the health and hospital system. So will we see the dropping down or closing of what's going to happen this Christmas in light of COVID?
Look, it hasn't been sorted through yet, but can I say you're right. When I was in opposition, I used to get very excited about that, and I'm sure you still do. But the reality is that I think at the moment everybody's exhausted in the health system. It's just terrible. Everybody has had it. GPs, though, always traditionally disappear over Christmas, and that makes it a bit of a challenge, particularly in regional areas, because often GPs are the ones who are backing in our local hospitals. So, yeah, there will be some, I think, winding back during that period, but anything that's urgent will still be done, as per always.
So there will be the traditional Christmas close downs.
I'm just saying that during that period, you always
activity.
Sorry?
Low activity over Christmas. We never close.
You can't close the health.
End it there. That's a good answer.
You can't close the health system. I mean, you just can't. But it's if you're on Category 3 or Category 2 elective surgery, it's very unlikely you'll find a surgeon anywhere in New South Wales wanting to do that work just after Christmas. And the GPs will be taking their Christmas tucker somewhere else. So, yeah, anyway, that's the way it works.
Thanks, Minister.
Deputy Chair, Honourable Emma Hurst.
Thank you, Chair. Morning, Minister.
Well, Emma, how are you?
I'm well, yourself?
Pretty good, thanks.
Good. I wanted to ask you a couple of questions about the new position around unvaccinated people. As you know, the date has changed from the 1st of December to the 15th of December. Can I clarify if that change came about as a result of health advice around? I mean, obviously we're still hitting pretty good figures in regards to first dose vaccinations. What was the health advice around that decision to change the date?
Look, I think it's fair to say that perhaps I should start by just explaining for those who are not familiar with it, and I certainly wasn't as familiar with it as perhaps I should have been when I was in opposition, that most people talk about public health as being the entire public health system, the free system that we operate across the country. It's not that. The public health system is a section of the New South Wales health system, and the public health teams are effectively the epidemiologists, virologists that sit in our 12 public health units around the state. They were established in about 2011, just as our government came in. So every decision that was taken during the entire course of the pandemic had the public health team, and the public face of that is Dr. Chant, but there's a whole number of other public health physicians in each of those local health districts. Indeed, you probably noticed Dr. Marianne Gale, who came in a bit later in the pandemic. She was actually in southeastern Sydney, I think, was that right? Southeastern Sydney. And then she became part of the team because we needed some extra energy, I suppose. We were all just tired. So she came in to help us with all those things. And so their advice was one factor all the way through the pandemic. But then when we were saying in our press conference, for example, that based on health advice, it was a mixture of the public health team's advice, the team who represented people, for example, concerned about mental health, the people who represented, for example, the broader system advice. Can a public health advice be operationalised? And Susan Pearce is very much involved in that. Can what public health thinks we should do actually be done? Mm-hmm. And then, of course, the economic advice and so on. So all the way through, it has been a balance of advice given to the Cabinet, and then, of course, or the subcommittee of the Cabinet, and then the subcommittee of Cabinet made the decision. So it's fair to say that every decision that was ever made was a mixture of those things. The 15th of December issue was very much around, I think, primarily the concerns from public health about public health would always like longer, a lot longer, because that's their focus, the epidemiologists and virologists. They would always like longer to try and get everybody vaccinated. So the extra couple of weeks was something that they were quite supportive of. And it was a balancing act. If we were moving forward with some of the other returning to normality, if I can call it that, then it seemed reasonable to also give a couple of extra weeks to try and encourage people to get vaccinated. As you just heard Deputy Secretary Minns talking about, health's attitude has always been encouragement, not forcing, but encouragement of people to get vaccinated and to understand that vaccinations keep you safe but everybody else safe.
I mean, obviously, there's going to be a natural drop-off over time. I mean, obviously, when we were really in lockdown, just in regards to the vaccinations, obviously a lot of people went out quite quickly and got vaccinated because that's what the situation was calling for. And so we saw quite rapid increases in numbers of people getting those first doses early on. And obviously there's going to be a natural drop-off of people seeking that first vaccine to a degree. But did that sort of was that drop off quite dramatic compared to what was predicted when that first announcement came through around December 1?
No. Can I go back to your first premise? I don't actually agree with that because there were varying levels of enthusiasm across the last, it was really only February, I think, when we finally got vaccines available in New South Wales. And initially we were a bit...
Oh, yeah. I just mean when we went into those lockdowns, there was a lot of people obviously then going to get vaccinated once we were in lockdowns and once there was a really strong push for people to get vaccinated. There was a very big increased demand for people wanting to get access to vaccines,
You
for
mean
example.
people became more enthusiastic when the lockdowns happened? Yeah, that's certainly
Yes,
true.
yeah.
Because people
And the
suddenly
numbers were
realised,
increasing.
I mean, there wasn't much good about the lockdowns except the fact that it did actually act as a catalyst for people to become aware and on their radar
Yes.
that, gee whiz, I better get vaccinated because this is serious.
Yeah, absolutely.
yeah.
Sorry,
And the
that's
same
what
thing happened in
what I mean is
Victoria,
that,
actually.
you know, like the people that, you know, wanted to get vaccinated in that period, what did you say, 90-something% first doses. And so, you know, the huge majority
Now,
of
you mean
people,
now?
yes,
Yeah.
over that time. But I'm sort of saying over the next few weeks, I'm assuming, even though people probably are still going to get vaccinated, that number has dropped off
Oh, I see.
somewhat.
Okay, yeah.
Like,
Yep,
we don't
yep,
need
I
these
agree,
mass
I agree.
vaccination hubs with big
Yeah.
lines and things like that.
I think what we're dealing with now, and I'll ask the experts here rather than me, but my understanding of what's happening at the moment is that we're dealing with the last small, most reluctant group
Yes.
to get vaccinated. And there's a variety of reasons. I mean, some of them still think, particularly young women of fertile years, women of fecundity, think that somehow it's going to affect their fertility, and yet all the evidence is the precise reverse. You're more likely to have problems getting pregnant if you actually don't have the vaccine, because if you don't have it, you'll end up possibly getting COVID and have long COVID, which will make things difficult. There's a whole lot of reasons. I mean, I hear people telling me that, we're waiting for some other vaccine that hasn't arrived in Australia. But I also think there's a psychological factor operating now, and that is that people who have been so indignant about getting vaccinated aren't going to admit that maybe they were wrong. And so there's this pride thing, which I would just say to all those people out there, pride is a problem. Don't let the pride get in the way when it can keep you alive and keep your parents alive and keep your kids alive and all the rest of it. Go and have the vaccination. But yeah, it's getting harder in this last little bit. Yeah. Do either one of you or any of the team on the...
Minister, I think you've covered the issue. I mean, we knew always that there would be a group of people who would remain resistant to being vaccinated. The clear evidence for the record, however, is that vaccination is extremely protective, and we've seen that in terms of our predictions, for example, for ICU numbers, which you saw tail off dramatically, and that's the experience in overseas countries as well. So what we see every day is that protective effect of the vaccine, and we have tried to think of all manner of ways to encourage people to be vaccinated for their own health and well-being as well as the rest of the community.
Do you think that the extra 2 weeks will be another incentive for people to get vaccinated, because now they've been in lockdown for so long that moving that date could actually incentivise some of those people who were resistant?
I think that was probably one of the aspects of the thinking that public health had, and it probably is right, but is there any accurate science about this? No, but it gives us another 2 weeks to try and encourage people to go and get vaccinated. So that helps.
Do you think that date might move again, or is that pretty solid now?
At the moment, I would say that it's very solid, yeah.
Are we worried about... I mean, the date of 15th of December is obviously 10 days before Christmas. It's when people are moving about a lot more. Are there concerns from the Public Health Department in particular around allowing unvaccinated people out when there's probably just 10 days before Christmas, when there is a lot more interaction amongst people? I don't know if that's going to increase the risk for them.
I think it's fair to say that public health, going back to what I was explaining a little earlier, Emma, will always be concerned while we have any people in the population who are not vaccinated. They want everybody vaccinated. Having said that, can I remind people too that you've still got to be cautious, even if you're vaccinated, be a little bit sensible. I don't know that everybody is being that sensible, but still, because you can still get the virus and you can still transmit it. It's just that it's far less likely you'll end up dying, far less likely you'll end up in hospital, and considerably less likely that you will get it and transmit it, but it's still possible. Yeah. So, there's a 1 in 100 year event. None of us have seen it before, and none of us really still fully understand what this virus is capable of doing in its various forms that it might morph into.
Yeah. Just another question about the vaccine boosters. I'll just try and get one more question before my time's up. I'm just wondering if there's any sort of discussions around any kind of automated reminder system or anything like that, particularly given some people might lose track of time around those boosters. Is there any discussion around, encouragements and nudges, I suppose?
I think you heard Susan say, Deputy Secretary Pearce say before that she had put out, or the team had put out 70-odd thousand reminders to the health team. But I'll ask Ms Pearce to answer that.
Minister, as I mentioned earlier, yesterday we issued over 71,000 SMSs to people for that very purpose.
Thank you.
Kate Fairman.
Thank you, Chair. Morning, Minister.
Morning, Kate.
Just wanted to go to, obviously there's going to be a backlog of, a lot of things that the hospital system is enduring now. I wanted to firstly just start with breast cancer screening. There were reports that up to 98% of all appointments were cancelled during the lockdown. What is New South Wales Health doing to support what I assume is a big backlog of women getting mammograms and...
Look, that was a really tough decision by Health because it wasn't a government decision, it was a health decision. And it was about, obviously, when you're having a breast screen, you're in very close proximity to the people who are providing the screening. And it became a question of what was the balancing act there. As I said, and as Dr. Chanton, I think probably other doctors said at the time, that it was a tough decision, but women who should still have been encouraged, and they were by us and I think by their doctors, to do the sorts of self-examination that they would normally do anyway in the normal course. And if they had any concerns about a possible lump or other indicators of concern, that they would go to their GP and have the GP assess the situation and send them off, obviously, for screening as necessary. The current arrangements, as I recollect, were put in place as things got a bit tough in August. So it's around about the 12th to 16th of August, something like that, that we actually did have Health make that decision to effectively minimise exposure through the breast screening, broad-scale breast screening. Clearly, there are women who have need to get back, and I think it was maybe a few weeks ago. It was certainly when we were doing the regular press conferences that I announced that we were re-implementing breast screening, and I encouraged women to go back into that process. And certainly, Breast Screen New South Wales has been contacting people who missed out. And getting them back in for breast screening.
Are you aware of whether there is a big waiting list or backlog of women wanting to be screened?
Kate, I'll ask whoever's the most expert, and I'm not sure because I've got all these officials around me, who would be the most expert on such matters?
The advice provided by the Cancer Institute, because the Cancer Institute looks after our breast screening services that are devolved and managed then locally within the districts. The priority will be to contact women whose appointments were postponed or invitations delayed, because there is a time cycle of preferred screening process. But I'd reiterate too that from the last lockdown that we had last year, when we postponed or stopped services for a duration, the impact in terms of getting people back into the program was minimal, and we're optimistic also that we'll be able to manage the number. I don't know what number were rescheduled or postponed, but we can take that on notice.
Yes, it does. I do have something here from the National Breast Cancer Foundation. This is nationally, but it does say that they are worried that there may have been 2,500 missed or undiagnosed breast cancer cases, and that the breast screenings dropped by 98%. So that's a significant backlog. But thank you for taking it on notice.
And I think that's the critical issue, if I may. Screening is screening, it's not diagnostic. And as the Minister emphasised, the messaging that we gave to everyone involved, if you have symptoms, please present to your GP, and then the diagnostic testing will be undertaken. And that's the important critical issue. Screening is just for screening purposes, then with referral on for diagnostic intervention if necessary.
Thank you. I wanted to just turn to another backlog, which is even before the Delta lockdown, the number of patients requiring emergency surgery was increasing. I've got the stats here that there's been a rising number of patients needing emergency surgeries, which are increasingly relying on private hospitals to clear backlogs. So within the last quarter of 2020, there was 62,151 elective surgery procedures, which was 4,500 roughly, more than the same period in 2019. I just wanted to firstly check whether, is that the understanding that that basically patients are presenting more needing emergency surgery, that there is a general increase over time in the last few years?
Can I just say this first of all? There was no reduction or stopping of emergency surgery, and you interspersed the words there, which I think just needs some clarity. Emergency surgery versus non-elective surgery, or is non-elective surgery, but elective surgery is in three categories: category 1, 2 and 3. Category 3 and some of category 2 were what was selectively slowed down, if you like, not negated, but slowed down because of the more pressing pressures of freeing up staff to address what could have been a terrible situation with COVID, and has been in other places. Thankfully, we've avoided the worst of it, but still. And in terms of in terms of elective surgery, that has largely been private hospitals and public hospitals have been reinstituting the category 3 and category 2. Doctors were encouraged, actually, Kate, during that period. I mean, obviously, it's a subjective decision by a professional person to determine whether or not you should be in one of those three categories. And if they were in category 3 and a patient had a real problem, they were encouraged in public messages from us to go and talk to their doctor and get themselves recategorised. Sometimes that happens anyway, because obviously you can deteriorate. Forget COVID, just out of the context of COVID, your situation can change as you'd expect. So patients were encouraged to go back to their doctor and get themselves recategorised if they thought that it was deteriorating or causing them, particular problems. Where we're at now is that obviously we've stepped up because of the drop-off in the COVID requirements. Just emphasise again, the worry was that we would be overrun. I think the words that the ICU specialists used were overwhelmed in October. That was the modelling that they put together that we were relying on, and the system would be overwhelmed. We would have still managed it. I just want to stress for those who didn't follow this closely that we would have still managed it. Because a lot of steps were taken to reorganise patients who had been in ICU to move into, if you like, a slight step down ICU that was usually located right near the existing ICU, so they'd still be managed by intensivists. Net result, those staff in the end weren't needed as much as we thought they would be. So we've gone back now to getting back to the Cat 1, Cat 2, Cat 3 elective surgery. And all I can tell you is that I know when I look at the figures, even under what we have done in a COVID 1 in 100 year pandemic, there are still less people waiting than there were under the former Labor government during their 16 years at their lowest point. And that's not to reflect necessarily on the Labor government, just pointing out these things happen from time to time. In the, well, no, I don't want to reflect on that. I think it's just a reality of health that these things can vary. Does anybody want to add anything to that?
I'm happy to comment, Minister. During the obviously it's been a difficult period for the last 18 months. You'd be aware that the Commonwealth imposed a suspension of non-urgent and semi-urgent surgery last year. So at the end of June 2020, we had over 100,000 people on our surgical wait lists. We'd actually managed to bring that down to 85,000 by the end of the financial year just gone, which was a magnificent effort by our health system to be able to achieve that. We also had an additional almost $460 million that was invested to fast-track surgeries which had been delayed due to COVID. There is further money this year that's available for that same purpose.
Is that largely so $460 million? So would that be largely paying private hospitals to clear?
No.
Right.
No. So it was a mixture. both between the public and private system. Our private hospital colleagues helped us considerably, as you would expect during a period like this. As the Minister's mentioned, our clear messaging was that if you're on one of the lower categories for an elective procedure and you felt your condition was deteriorating, to please see your doctor so that we could upgrade if necessary, or the doctor would upgrade them clinically. Urgent surgery was continued to be performed on time at very high rates. So the interruption to urgent procedures was not the issue. It was the interruption to the semi and non-urgent procedures. Yeah.
I'll continue later. Thank you.
All right, Second.
Thank you, Mr. Chair. Minister, I just want to return back to the booster shots and to the. In your answer, you mentioned that the Kudos Stadium Mass Vaccination Center was going to close. What will be the last day? Because I understand you explained that it will be closing because of entertainment commitments at the stadium, which is understandable. So what will be the last day, the closure day?
It's pretty soon, but can I just do a little plug here? Anybody who wants to sponsor quarantine workers or health workers, is it the 8th? What day is it?
Monday, yeah.
Monday, next Monday, there's a big celebration for the people who have committed themselves so well in the last 2 years in every aspect in the quarantine job. So health staff, cleaning staff, police staff, and health is facilitating a get-together at Kudos. Mm-hmm. And I think because of government restrictions, of course, we can't fund a drink or two for them. So if anybody wants to sponsor health workers or police, contact Susan Pearce, Deputy Secretary of New South Wales Health, to make sure there's good food and good drink to thank all those health workers. And to all the health workers out there, I just want to say thank you. And there were thousands of you who actually kept our quarantine system operational and did an amazing job. So thank you on behalf of, I'm sure, not only the government, but also, I'm sure, the opposition, Mr. Secord. Would that be right?
Absolutely.
Okay.
If I may, Mr. Secord, Graham Loy is the Chief Executive from Western Sydney Local Health District, and he was responsible for the Kudos Stadium Vaccination Initiative, so he may be able to assist with more details.
Thank you very much.
Okay, Graham, you're starring.
Well.
Thank you, Graham Lloyd from Western Sydney. So Kudos Bank winds up on Sunday, so in 4 days' time will be our last vaccination out of Kudos Bank.
How many people have gone through the facility?
That's a very good question. Can I take that one on notice?
Yep, thank you. My colleague Courtney Hughes now has questions. Thank you, Mr. Lloyd.
Ms. Pearce, you said earlier that that 71,000 SMSs were sent out yesterday to people who are already eligible for their booster. Is that only people who have been vaccinated through the state hubs? Is that right?
Yes.
Oh, sorry, you go.
I was just going to say we have had conversations with the Commonwealth with respect to whether or not it would be possible to use the Australian Immunisation Register for that purpose, because they essentially hold all of that information. They are looking at that. We're also aware, obviously, that our GP colleagues are similarly contacting patients who've been through their practices for vaccination. So we didn't want to wait until there was a perhaps Commonwealth solution or a centralised system. We were very keen to communicate with people who had been in contact with us. Even, for example, if they'd received their second dose elsewhere, we've contacted everyone. Yeah.
And have you spoken to customer service so that through the Service New South Wales app, that people who might not have received it through the state hubs but have registered through Service New South Wales that they are double vaccinated, that they could then receive a notification?
We work very closely with customer service. They certainly are involved in the communication around the booster. As to the ability for them to push out messages on that basis, I would need to check. But the nsw.gov.au website that they manage has the information about the boosters and the links that are available for people to make a booking.
One of the issues there, Courtney, is that whilst customer service might be able to do it for New South Wales, we have a lot of people moving back and forth between states and territories. So I think ideally it would be better if that were pushed out through the federal government to all of us. And Susan just used what we refer to as the AIR system, which she didn't actually explain, but it's effectively the immunisation register for the whole of the country. So it'd be far better if, say, you were here and then you were going to live in Queensland, that you got it up there. Otherwise, there'd be massive missing out. So, but we've actually backed in quite well. We provided alternatives, necessary alternatives, in a number of circumstances where we felt that perhaps New South Wales could more effectively deliver aspects of looking after the community than perhaps the federal government could, because we're more experienced at frontline services than perhaps the federal government. But I still think with that one, it would be preferable, and I state this categorically, it'd be preferable if the federal government did that.
I understand that. Thanks, Minister. I wanted to move on to another issue. You and I both have our little attractive green armbands this morning because we've been rapid tested.
Very attractive.
In order
Goes
to,
with part of my socks this morning, I discovered, so that's good, yes.
In order to come into the building.
Yep.
Are there any plans to start rapid antigen testing in our hospitals?
Well,
if I could suggest Dr. Nigel Lyons, he's been leading the rapid antigen testing program.
Okay.
Dr. Lyons.
Yes, Nigel Lyons speaking. We are already using rapid antigen testing in our hospitals. We introduced rapid antigen testing in our acute mental health units at around 2 months ago as a result of some outbreaks in our acute mental health units you might be aware of.
Yes.
And that was done because some of those patients had not been able to uptake the opportunity of a vaccine and were at higher risk of coming into a facility and could potentially bring that into an environment which was full of very vulnerable people. So those rapid antigen tests have been available on the advice of our experts every third day for acute units across the state.
And is that just limited to acute mental health wards?
Yes, we've been looking at the advice coming through about the utility of rapid antigen testing is emerging internationally because, as you know, these are relatively new tests.
Yeah.
They're not a diagnostic test because while they're sensitive to coronavirus, to COVID-19 and the Delta variant, they're specific to that. They're not as sensitive as the PCR tests. And their sensitivity is such that they're at risk of giving both false positives and false negatives, which can be a problem if you're trying to use them in a diagnostic sense. So it's much better done. This issue around the lack of sensitivity can be overcome by repeating the tests. So that's why they're usually recommended to be done in a sequential way and over time. So a one-off test is of some assurance but can't guarantee that you don't have an infection with COVID.
And, sorry, Dr. Lyons, if you can just explain, that they're only for the acute mental health wards. You don't have them currently, or you don't have plans to expand them more generally through the public hospital network at the moment?
Well, no, our advice is that for people who are suspected of having COVID on admission or being assessed in our emergency departments, it's better to get a rapid PCR test because it's much more sensitive and is a diagnostic of COVID. So that's the advice that our healthcare professionals have, is that they undertake a PCR test in those circumstances. Rapid antigen tests are more a surveillance and screening test. As I said, they're not a diagnostic test. So in an environment which is high risk and where it's really important to definitively know whether somebody has or has not got COVID and aren't able to be tested in an ongoing way, the advice is to do a PCR test.
And you just said that there's a propensity for false negatives. I'm not sure that I think most people accept that there's a propensity for false positives, but can you just explain about the false negatives?
So what a false negative is that it's while the rapid antigen test advantage is that you get a test result within 15 to 20 minutes, the issue is that a negative result does not rule out the fact that you may have COVID. It can't guarantee that you don't have COVID. So this is the reason why they're not being used more broadly, because they don't definitively rule it out. They are much more effective in the early stages of the infection. So when the viral loads are higher and where somebody may be asymptomatic, they're actually very useful in that circumstance because they may detect the virus because there's a high viral load and the person's not aware that they may have been affected. And over time, their use is actually reduced during the course of the infection. It's an issue about why they haven't been used more broadly at this stage, because they don't definitively rule out.
So what Dr. Lyons was saying is over the course of the infection, the viral load obviously drops. So at that point, it becomes a little less effective. But there's always the challenges around the use of those particular tests anyway.
So I understand that. So there are false negatives and false positives. So when you do polling, you do margin of error, you say 3 to 5%, that kind of stuff. So if you're...
You go straight to polling, do you? That's good. Okay.
No, but what I'm saying is that there's a margin of error. So if we're getting tested downstairs when we come into the building or we're coming in off the street, so you're telling us that, well, why are we doing it then if there's like false positive or false...
I stress, since I don't want the health team to be wearing any of this, that the current arrangements in the New South Wales Parliament are not as a result of advice from New South Wales Health. They were an independent consultant, as I understand it, that gave advice to the Parliament. So don't blame New South Wales Health for the fact that you have rapid antigen testing here.
So what is Dr. Lyons? So can you give us an assurance or a description or a context? So this is the first time I've heard of false negatives. I've heard of false positives, but this is the first time I've ever heard of false negatives. So what's the margin of error with the RAT tests, the rapid antigen testing? So give us a context.
So it varies on the different tests that have been reviewed.
What he's about to say is rapid antigen tests, depending on the manufacturer and the actual device or particular, have the different margins of error, I think. Well, you go on, Nigel, sorry.
Yeah, so at the best, they're around about 60% sensitive, whereas a PCR test is around 95% sensitive. So you can see the margin is quite significant. And there are some that have been approved that have got less sensitivity than 60%.
They're an extra tool. And if Dr. Chant were here, she'd be telling you that there are various layers of protection. It's an extra tool that can be used. And, you know, whilst I have a view on it, I'm not going to express that, but the Parliament has chosen to...
Well, you're welcome to, Minister.
You're welcome to, Minister.
Very kind, Mr. Chairman, but I won't. I've expressed that view already.
You don't normally hold back, Minister, with views?
No, I don't normally, but on this occasion...
You're invited to proceed.
No. I've expressed my views privately to the Speaker, and that's a matter for him and me. But anyway, for the moment, it's an extra layer of test, just like having a mask, just like maintaining 1.5 metres social distance. It's an extra layer of protection. It ain't perfect, but it does some work.
Okay, Dr. Lyons, you used the word sensitive in relation to 60%. What does 60% sensitive mean?
It's about the percentage of likelihood that actually detecting that the virus is present in the body, and if it's there, it reliably detects it. So 95% is the PCR, at my understanding, around 95% for the gold standard PCR. And rapid antigen tests around 60% sensitive.
How long does it take to get back a PCR test?
Well, see, PCR tests,
So PCR tests, the majority of those are turned around within 24 hours, but that varies in some geographies. So the other issue around where a rapid antigen test would be of benefit is if you're in a place that is geographically distant from a laboratory that does the PCR testing, and it would take longer than the 24 hours to get that test result turned around. So it's a benefit to do them in situations where you might have a community that are remote, isolated, and you want to screen a number of people in the community to make sure that you've got an ability to detect the virus if it's present. Not at the same level of standard as a PCR, but still nevertheless of benefit in assessing the spread of virus in the community.
It's all improved in the last couple of years too, because PCR tests, polymerase chain reaction testing, was taking quite a long time, in the sense it could have been up to like 48 hours in the various labs, but it improved over time with the expertise improving. And in fact, there are some subset PCR tests that can actually be turned around in literally 2 or 3 hours now, but they're a little more expensive, and so it's a matter of when you're doing what you're doing, what's the actual value of it? And as Dr. Lyons says, if you're out at Gadooga, for example, you might find that if you need to do some fast screening, at least there's value. There could be value, depending on what the issue is, in using a rapid antigen test.
Yep.
Yeah.
Now, just back for clarification. So, in the acute mental health units, you're doing the RAT tests or the PCR tests?
Well, Dr. Lyons again.
So the rapid antigen tests are being used on patients who are admitted, and they're being done on admission every third day during the course of the admission, and that assists with this issue around sensitivity. So the advice from experts is if you repeat the tests every 2 or 3 days, your chances of having a false negative that's not picked up is reduced. So it's actually a benefit to continue to do them sequentially.
Okay, thank you.
We're also doing them in our staff and ambulance service, particularly in communities where there have been high rates of transmission in the community. So we introduced it in that environment as well. And we've also been undertaking in some of our really important support services that have functions that supply services to the rest of the health system, like the laundries and the kitchen services. So some of the staff there have been undertaking rapid antigen testings on a sequential basis as well.
So Dr. Lyons, with the 60% sensitivity on the RAT tests, so it's probably, with 60% sensitivity, it's probably only useful if it actually comes up with positives rather than negatives. Because if there's a positive, you can then pursue that check and verify. Whereas if you get a negative, well, it's a negative, but it could be wrong. So if you get a positive, do you understand? Am I following?
It's true.
Am I following?
And if you get a positive,
Sorry. Overcomes that issue, Mr. Support. So that if you keep on doing them every 3 days in somebody, you're much more likely to pick up the person having COVID.
Okay,
the sensitivity issue is overcome because you're continuing to repeat the test.
Okay, I
But
see.
of course, our advice always is, even if there is a non-negative rapid antigen test result, the requirement is to immediately get a PCR test. So to overcome this issue of the false positives.
Okay, thank you, Dr. Lyons.
Minister, during the lockdown, residents from the LGAs of concern were required.
Sorry.
Minister, during the lockdown, residents of the LGAs of concern were required to be COVID tested before entering public hospitals. Yet as recently as a fortnight ago, this was still flagged on the check-in system for public hospitals. Why is this when LGAs of concern were supposed to be abandoned when we reopened?
I don't think that is necessarily the case. Some of the hospitals and some of the health districts obviously go back a step. There are broad advice that comes out from the Ministry of Health, and then the local health districts are independent and they make decisions. There are 15 of them. They make decisions based on their own local circumstances. And you're referring specifically to which parts of the...
To the check-in system that
but
you use.
which areas? What areas are you talking about?
The specific example is at the Prince of Wales Hospital in Randwick.
Oh, yeah.
And it
What are you
comes
saying they're doing?
up. So if you check in using the system that checks you into any public hospital in New South Wales, it comes up if you are a resident of a local government area of concern, what used to be called a local government area of concern.
I'll ask one of the experts. Which expert do I have here that can
I'll
answer
provide a brief comment and then pass over to Nigel, because Nigel led the clinical group about what we call the risk matrix and how we adjusted changes in settings according to transmission rates.
Ms. Koff, can I just ask you though, yes. But what is it currently? Is it your...
No, the LGAs of concern do not exist anymore as an entity. It was only while transmission was high that the LGAs of concern and their residents were classified as authorised workers. And what we did then, we moved to harmonise the first step for Greater Sydney. So, Nigel, did you want to provide any comment on the
I'm not
matrix?
interested in the history, and we are running out of time, but I'd like to know whether this is still the case if you check in today at public hospitals across the state.
But you just said Prince of Wales.
Yes, well, that's one example, but it's the same system,
Oh, so you're
Minister.
saying it's right across the board?
I'm saying it's the single, it's a single check-in system.
Well, I don't think it should be, but I'll check with Nigel. I think there might be, maybe the local hospitals hasn't got it right, but Nigel?
So thank you, Minister, and thank you, Elizabeth. So the advice that's gone out to all our hospitals right across the state, and we've reviewed this in the last fortnight with the risk escalation panel, is that there should be a limited number of screening questions that are undertaken, and it does not include that question.
I should just let Greg do it.
So if there is a check-in procedure that's being undertaken at any of our hospitals that includes that question, it is not on the basis of our current advice out to the system about the 3 or 4 questions that should be asked.
Okay, so there should be no...
Not one of the questions that we recommend.
There are no LGAs of concern, so it sounds like someone hasn't actually sharpened up their act at Prince of Wales Hospital. They're generally pretty good, I got to say, and I can guarantee if you want good medical service, go to Prince of Wales Hospital. But if you're going to get asked that question, that's not. Yeah,
I'm not
unfortunate.
disputing that, but I'm saying, Minister,
There's about
there
400
are still...
health facilities across New South Wales and 140,000 staff, up to 176,000 you heard before, and not always does every one of them get it absolutely right, but mostly they do.
Minister, I'm not actually talking
And I
about
love
the
you all dearly.
staff. I'm saying about, and it's
Order.
certainly not a reflection on the
You too,
care,
Mr.
on the
Chairman.
quality of care that they provide. But if you are using this standardised check-in system, you are still flagged if you're a resident of those former LGAs of concern. So let's just, can I just be clear?
That's not a standardised system, Ms. Hughes. So that check-in system would be unique to that hospital or local health district.
And that's what I was saying.
The local health district?
So it's not a standardised.
That's why I said to you, the ministry sends out guidelines and directions, but then the 15 local health districts have to actually put those in operation. They might have been actually more focused on looking after patients than worrying about what is a technical aspect.
Order, Minister. Order. The member is actually asking questions.
Yeah, and I'm answering it.
Well, the issue is, I think they're pretty straightforward questions being asked.
And I'm answering it.
I think the editorialising around the 15 health districts...
No, that's not editorialising. That's actually explaining how the system works.
Minister, it was a straightforward question from the member.
Mr Chairman, I answered the question.
Excuse me, Minister. Mr Lyons interposed and provided some information.
Yeah.
The Honourable Courtney Hughes was trying to get to the bottom of a particular question.
Yeah.
Okay?
Yeah.
So can I just...
And I was explaining it. I don't know why you're saying I'm not. I was.
I didn't say you weren't, Minister.
Final question, to be
I'm not
clear,
sure what you were saying,
there is no requirement now on patients to receive a COVID test before they receive treatment at a hospital.
Say that again. What?
There is no
That's a different question to what you asked before. Say that again.
There is no requirement now on patients to receive a PCR test before they enter hospital. Is that correct?
Well, I think it's looked at in each patient that comes in, depending on the circumstances, may or may not be given a COVID test depending on the clinical assessment.
But it's not a requirement before they enter. These.
Well, the point you were making was that if they came from an LGA of concern, that is not an issue. That is not an issue. Okay. That shouldn't be the case. It should be on a clinical basis, individually for each patient.
Okay, thanks, Minister. My time has expired.
Deputy Chair.
Thank you, Chair. Just jumping back again to the boosters, am I right in believing that at the moment it's just Pfizer that's being used as a booster? Is that right?
Correct.
And is there going to be now a movement for the other vaccines as well to become available as boosters?
It's a matter of regulatory approval and application by the vaccine companies for that purpose. So Pfizer had submitted and was given approval for that purpose. Moderna's been encouraged to do similarly. Mm-hmm. AstraZeneca can be used as the booster, but the Commonwealth and the ATAGI has made it quite clear that Pfizer is the preferred, or mRNA vaccine is preferred.
And obviously earlier we had quite a few problems around getting the Pfizer into regional, rural and remote areas because of the temperature issues. Are we still having those issues in regards to getting the Pfizer out for the boosters, or is that all resolved?
No, because the advice, you're right, early on the advice that came out from the TGA and the ATAGI was that it was challenging because the Pfizer vaccine, the mRNA vaccine, had to be maintained at about -70 to -80 degrees. And that presented all sorts of challenges early on because there were very few fridges in New South Wales and Australia, actually, that could actually maintain that temperature range. We actually had to borrow some from research institutes and others to be able to look after the vaccine going in. But somewhere along the way, maybe about 6 or 8 months ago, ATAGI changed. Well, go back a step. The way we did it was that it was then allocated to particular locations around the state, and then it would go out in special insulated material to keep it, and you could keep it for about, I think it was 6 or 7 days at the lower temperature, and that was all good. It worked, but the advice changed from the federal government about 6 or 8 months ago, as I recollect, and said that you can now actually transport it in easier circumstances and maintain it at the lower temperatures. So no dramas now about getting it out to the various venues where boosters will be allocated.
Great, thank you. Thanks for that. In regards to the self-isolation rules, Is there a proposed date or a potential to scrap the isolation of close contacts in the future? We've obviously heard a lot of people saying eventually it'll be treated like a common cold. At what point are we looking at on the timeline of actually getting rid of some of that contact tracing and some of that self-isolation without symptoms?
Look, at the moment, it is presenting challenges to define what happens in certain close contacts and casual contact circumstances. And the public health team are working on that. But I think, eventually that will pass, but not in the next few weeks. And public health has got that under review at the moment. And almost every day, the AHPPC, which is a group of, it varies as to who's on it, but Dr. Chant or members of her team are on it every day. That's all of the virologists and epidemiologists and what have, and similar expertise, people with expertise, get on a meeting every day and discuss what's going on across Australia, and they share their experience and their advice, and out of that comes advice to all the state and territory governments through their own public health units. So Dr. Chant would normally, when it was really high and was worrying us all very greatly, Dr. Chant was on that phone call for 2 to 3 hours a day, amongst all her other work. But these days it's less so. She normally has a delegate on there, or she perhaps does it every now and then. But that's an unclear position yet, and it'll need to be a position which probably all of us adopt all across the country, accepting that there's some challenges in some of the states that really haven't had, still got barbed wire fences up on their borders, Queensland, WA and so on.
So do you think that but do you think possibly next year we could be looking at that kind of a change?
Wishes to add something?
Yes.
If I may, what the Minister described too was part of the process that fed into the National Plan for Reopening. And the National Plan for Reopening was predicated on the modelling of the Doherty Report and the recommendations for the Doherty Report. It defined those milestones of 70% vaccination, 80% vaccination, 90% vaccination. But in conjunction with those levels of vaccination, there's still a requirement for what we call TTIQ, test, trace, isolate and quarantine, and the social measures. So the main thing that we emphasise to the community, vaccine and vaccine alone will not stop the transmission. So that's been very strong in our messaging to the New South Wales community. With the vaccination rates higher, however, it's required us to rethink what test, trace, isolate and quarantine looks like.
Yeah.
So if you are vaccinated, in the past it used to be 14 days in self-isolation if you've been in contact with a case of COVID. Okay. Now we've revised that if you've been wearing masks, if you were socially distanced, you may not be required to self-isolate as long, and in some instances we're saying 7 days, and then test at 7 days, and if it's negative, you're free to go. So it's adapting all the time, and I think that's one of the biggest challenges for us, to keep adapting the messaging. But there's definitely not a time frame listed as to when those might be fully eased, and we'll take advice from the National Plan on that.
Thank you for that. I noticed on the New South Wales Health website it also says if you've had COVID-19 in the past 6 months that you will generally not be considered a close contact and do not need to self-isolate unless you have symptoms. Does that apply as well to anyone that's unvaccinated?
Well, if you're unvaccinated and you've had COVID, yes, because what it's really referring to is the fact that your immune system has developed antibodies for that period, and so you're in that situation, yeah.
Is there a verification process that will be undertaken to determine that someone has actually indeed been diagnosed with COVID previously?
I'm sorry, I don't understand the question.
So if somebody says, I don't need to self-isolate because I've previously had COVID, will there be a way to actually identify that that's correct? I can see some nods either side of you there.
Which of the experts wish to answer this one?
You go ahead, Sue.
Yes, indeed.
Thank you.
We've made arrangements to assist people, because obviously that presents a rather difficult situation for them, that they have a medical clearance letter and a QR code link that takes anybody who wishes to check to ensure that is in fact an authorised and original document. Also to note that the latest advice is for those who've had COVID, depending on advice from their doctor, they may indeed now be vaccinated sooner than was originally thought. So at one point it was at 6 months. Post their infection, that's been reduced quite significantly, so that will assist them as well.
Thank you. Thanks for that. And I was wondering if I could get an update on the status of vaccination for children under 12 and where that's up to.
Obviously, we would like, well, as Health Minister, I'd like to see the vaccinations available for children. At the moment, what we're seeing is around about 40% of all new cases of COVID are for people under the age of 20, and about half of those are under the age of 10. So certainly desirable if we could have a vaccine available for children, well, all children if we could do it, but the focus is most likely to be on children between 5 and 11. The FDA has, obviously in the United States, has just in the last few days approved, I think it's Pfizer from memory, for use of vaccine or for vaccinating children at that age brackets. I'm hopeful, very hopeful, that before the end of this year, the TGA here, which is the equivalent of the Therapeutic Goods Administration, the federal body, the TGA, will adopt a similar decision-making as the FDA in the United States. It's will be a game changer for little kids, and certainly from all I've heard from my colleagues and friends overseas, there's been a fairly big enthusiasm for kids to take, or young people, children, to have it. So hopefully it'll be the same here.
And are we sort of, once that approval comes through, are we sort of all prepared and ready to on how that rollout will actually happen? I think last time I spoke to you, we were talking about, whether or not that will happen through the school system. Is that all sort of set up in place and sort of ready to go once we get the approval?
No, there's a lot of work going on at the moment about what might be the best way to do that. Initially, though, I think it'll probably be. I'll ask the Deputy Secretary in a sec, but my instinct is it'll be generally through the GPs and pharmacists primarily, but we will certainly be in a position to be able to provide it. There's a lot of work going on at the moment with education, looking at whether or not we could have a vaccination program operational through the schools in the same way as we do, for example, with Gardasil, and that's been operational for 20, 25 years, something like that. So I think that's under review. But Susan, do you want to add something to that?
Only to mention that we're working very closely with our GP and pharmacy colleagues on these issues, and I think it's important to acknowledge the role that they've played, in particular with regard to the vaccination of 12 to 15-year-olds. We've done our share, but certainly they have done probably the bulk of that work. At present, all of our local health districts are looking at the school vaccination program, and we will continue to play our part in that ongoingly. We're obviously very keen for all of those children to be vaccinated as well.
Thank you.
Thank you, Chair. Minister, I wanted to turn to the case of the celebrity cosmetic surgeon, Daniel Lanza, who that was the case that was exposed by Four Corners and the Sydney Morning Herald and The Age. Quite appalling stories, including at his Sydney clinic. Minister, I know that in, I think, 2016, after appalling situations of women dying at the hands of cosmetic surgeons, you introduced some changes. What is New South Wales Health? What more can New South Wales Health do to prevent what is still occurring in the industry, which is, well, essentially just appalling practice, which is butchering some women? That's still happening in New South Wales. What's New South Wales Health's response to the latest expose of this industry?
Rather than commenting on the specific doctor, I did actually see, I saw a fair part of that show. It was horrifying, actually. I'll just say this, that the problem of registering medical practitioners and allied health medical practitioners is done nationally through APRA, and there has been a high level of concern for quite some time now about the use of the word surgeon. That's what causes, I think, the essential issues. When you graduate from medicine, you generally graduate with a Bachelor of Medicine and a Bachelor of Surgery. So technically, even GPs can do surgery, but practically these days, I mean, and in past decades, that was absolutely crucial, because in the bush, in the regions, particularly in remote areas, GPs did have that level of obligation and experience that they could do some surgery, particularly around appendectomies and so on.
Because at a state level, I understand that, and this is what you, I think, as Health Minister, changed at the time with the kind of previous revelations about this industry. The state has the ability to regulate private health facilities. So there was changes, as I understand it. Yeah, in terms of licensing. So is there anything more further that can be done in that regard then?
I just want to emphasise that I have certainly, along with other health ministers, Labor and Liberal around the country, expressed concerns about the use of the term surgeon. And obviously, plastic surgeons require quite a number of years of training and develop their expertise. And cosmetic surgeons can sometimes, of course, have very minimal training. I'm going to ask, who would be the person who would know most about that?
I can provide some advice on that,
Thank you.
Minister. And back in 2017, a special class for the private registration of facilities was introduced, the cosmetic surgery class licence. It's important to understand that was introduced due to increasing concerns about cosmetic procedures in unlicensed and ill-equipped premises. There were some breast procedures under sedation that were problematic, which prompted us to do that. So we did introduce specific licensing standards for cosmetic surgery, and it is also an offence to operate an unlicensed facility doing those procedures of sedation. The ministry then obviously does regular audits of those facilities. So part of the compliance is that they advise that they're coming in to audit those facilities. However, also has a regimen of unannounced investigations where concerns have been raised.
With those audits, what's the notification period?
Unannounced.
No,
For the
you also
regular
said,
ones.
yes.
I don't know what the period is, but they are given advice to ensure appropriate staff are available to respond to any questions asked on the regular audits.
I think the reason Kate's asking that is on Four Corners. It said that there's a 4 to 6 weeks across the board that is given.
That's right.
Yes.
Yes, and in this situation, just absolutely disgusting stories of the human fat that was stored in the fridges that staff had to take home when the auditors were coming in. Clearly with notification, I mean, just horrific.
My personal view on that is we should be doing far more of the unannounced ones.
So, Minister, that's your personal view, but you're the Minister, so don't you think
I've raised
that
it with
should
Health,
be
and they're looking at those issues. But they obviously, as the Secretary just said, she's also pointed out that on some occasions they need to have the staff there to be able to talk to them, so they've got to give some notice to actually get the staff there. I think, as we saw from that thing on Four Corners the other night, some of those doctors aren't there very regularly. They're at different places all over the country, so that's part of the issue.
Do you know the proportion of the, maybe obviously want something to take on notice, but the proportion of audits that are with enough notification versus unannounced?
I don't know the answer, but I'll be interested myself, so I'll definitely get that. Can we get that
Certainly,
statistic,
we can take that on notice.
Is there anything else then? So, sorry, I interrupted you just to ask questions about the audit. So is there anything else that's being undertaken as well to strengthen compliance, to strengthen monitoring? Is the New South Wales Health under, obviously this, as a result of this, are you revising the way in which these facilities are licensed and whether you can do anything more?
Look, I think that this process, what was exposed on Four Corners, has highlighted the need for us to look at how we audit and inspect those to provide protection to the public, because that's what ultimately the issue is, the public safety. So we will look at that, as the Minister indicated, and the team is looking at that also in conjunction also with APRA. And I know the College of Plastic Surgeons is undertaking some advice too. So I think also there's collective responsibility both from the clinicians, the colleges, APRA and ourselves.
Kate, there's been quite a bit of work done at the national level when we actually had COAG, before it all got changed with this national cabinet business. The health ministers around the country, the state and territory ones, all share the same concerns. So, and we really need to have a uniform approach right across the country. Yeah. I don't think any of us were aware of just how bad that was as per the Four Corners. We knew it wasn't good, but I would expect that in the first face-to-face meeting we finally get of the after COVID settles, this would be one of the things that hopefully we'll be able to put on the agenda.
Do you know how that COAG, because in 2017, I understand that COAG met, and that was when they proposed a new national approach to target doctors without accreditations. So that was the new national approach. I'm not sure, what was set or agreed to, but is there any reporting back on that process? Do you regularly discuss this issue with your interstate colleagues at COAG, or is it kind of dropped off the agenda?
Last couple of years, as you'd be probably not surprised, it's basically been COVID.
Yeah.
No, but we'll be raising it with them, so I'm happy to report back on the next occasion. But,
okay. Okay. Just wanted to get to just a few questions in relation to COVID in the time I have left before the break. So long COVID. What resources is New South Wales Health putting into long COVID? Just in a general sense to begin with. I've got some more questions on this, but I assume that this is an increasing issue for the huge numbers of Australians who have caught COVID over the past 2 years.
We've had people in ICU for more than 100 days.
Gosh.
And long COVID comes with completely, muscle deterioration, wastage. So all of the allied health services that have to come on board with that. But who would be the most expert amongst the team to talk about that?
Dr. Lyons chairs the Clinical Council, and we engage with clinicians to seek their advice and input on how we have to modify services. So, Nigel, if you could respond to that one.
Dr. Lyons.
Secretary, so this has been discussed at the Clinical Council, and our clinicians are very conscious. The evidence overseas is that there are quite a significant number of people who are recovering from COVID and then have resultant conditions that are long-standing. And our communities of practice have come together and identified the need to develop pathways for care and resources that will support, and services ultimately, which we are considering how we'll organise around, as the Minister said, allied health and rehabilitation medicine, in conjunction with our respiratory medicine colleagues, and our infection prevention and control and infectious diseases specialists. So they're looking at what we need to set up that will be ongoing. So first of all, we'll be in the recovery phase. Following acute COVID, there can be some weeks and months where rehabilitation and support to recover from the acute illness is required. And then there's ongoing specialists to monitor for those other resultant clinical conditions that might occur under the banner of long COVID. So we're developing those resources now in anticipation that we will see a number of people who will need those services, and we'll need to organise how those services are arranged and how they're best delivered to ensure people can access that support and care. So that's under active consideration at the moment.
But Kate, what Dr. Lyons referred to as the communities of care, really that's all of those different health staff, specialists who need to come in and make those decisions. I was just while he was answering that question, just asked the Secretary, because I remember, I think we had a 21-year-old girl who spent 83 days in ICU, and I thought that was pretty bad, but the secretary's just told me we had one man who spent a year in the ICU. You can imagine when you come out of an ICU after a year, there's not much of your body left in the sense of muscles and all of the other things that go with it. So it's a lot of work to bring you back to a normal life.
Okay, we'll continue when I have.
Thank you, Minister. Thank you, officers. We'll take a 15-minute break now and...
Be back, Greg?
Well, at 20 past, yes. Thanks,
Thank you.
well, Now, commence. So we've got between now and 12:45 where we have a break. So we've got basically two tranches of 20 minutes each for opposition crossbench, and a little bit at the end, what may ever be left over, we'll split between ourselves. So we'll commence with the opposition. The Honourable Lord Secord.
Thank you. Thank you, Mr. Chair. This is a question probably to the Minister, and then if he wants to direct it to a public servant. Casting back, Minister, to the Ruby Princess matter, I understand that there is a push or a call to reopen or reactivate the cruise ship industry in New South Wales. Are there any discussions underway in that regard?
Certainly not from certainly not from my point of view as the Minister for Health in New South Wales. I understand there might be some discussions which are due in the National Cabinet.
Minister, my understanding is that something as soon as this week or early next week at the national level.
Well, those are matters obviously for the First Minister's discussions, but yes, it may be that there are discussions. I know the federal government is keen, or it seems to be keen, to reopen up to cruise ships.
What would be the New South Wales government's response, I guess, or advice from health? You know, I know that in some jurisdictions around the world, cruise ships are back, so to speak. What's the New South Wales health response to? I understand the push is coming from the federal level to reopen borders around the country. So, what is the New South Wales health response to federal government push to allow cruise ships back into various state and territory jurisdictions?
Look, there's been no position. I think that it is possibly a matter. You're asking me, Mr. Secord, about matters that relate to the National Cabinet.
Yes.
And there's no immediate,
I guess I'm trying to cut to the chase here, Minister. Would you support reopening New South Wales ports to cruise ships next week? As Health Minister in New South Wales, my job is to keep the community safe, and I have a real reluctance about cruise ships at the present time. Having said that, if the federal government chooses to want to reopen them, I mean, they were the ones in February last year that determined that 63 ships had to return straight back to port within a few weeks, within really a few days, which put a lot of pressure on New South Wales Health and other government agencies, as federal government agencies as well, to do what they need to do when ships are coming into port. Let me phrase this another way. Would New South Wales Health be ready to test or accept passengers coming into New South Wales on cruise ships? Would you be ready to do that?
New South Wales Health will step up to whatever task is required of them, but I must say, my view is that any such procedures, any such requirement should be a matter. Obviously, to bring them back in, you need to think about what safeguards you're going to have in place. My view, without having seen what is actually being proposed at federal government at the National Cabinet at this point, if it is this week, as you proposed, is that under the Federal Biosecurity Act, whatever requirements there are should be the responsibility of the federal government. If they were planning on sending it to New South Wales and therefore equally to each other state and territory to set up their own regulatory framework, that's not something I would feel very comfortable with, because each and every state and territory shouldn't be required under their particular legislation to try and put in place what could be differing standards around the country. The logical thing to do there would be to have it under the Federal Biosecurity Act and to establish the rules and regulations and for the federal government to administer it. If New South Wales Health and other government agencies that aren't in my purview, state government agencies, had to step in to assist, well, fine, but I don't think it should be the front line. I'm sorry. What I experienced last year is such that having seen what happened, I wouldn't want that to be something which could happen again.
So are there different regimes around Australia involving cruise ships coming in, standards, testing at the moment?
At the moment, there are no cruise ships coming in.
Oh, yeah, okay. if they were to come in, are there in fact different regimes in place from Queensland, New South Wales, Victoria?
At the moment, well, I guess what you're really asking is under the former arrangements. Yeah. Obviously, there were nuanced differences in each state and territory, but my view is the experience of what occurred in a number of states, not just New South Wales, should be that it should be a federal government responsibility to set those requirements and be responsible for the outcomes. And it shouldn't be up to New South Wales, but that's only my view, and it certainly isn't something that I've discussed with the Premier or with the Cabinet.
So will tomorrow's National Cabinet be Premier Perrottet's first National Cabinet?
I don't think so.
Oh, okay. So back to cruise ships. So you're saying that
I don't know. I don't get invited to National Cabinet, which is a blessing. But I don't know.
Okay, but you provide advice in relation to matters relating to COVID. So what will be your advice to the Premier involving cruise ships coming back into New South Wales?
Extreme caution.
Thank you, Minister. I'd like to direct a quick question to Mr. McLaughlin in Western New South Wales. Is the government COVID response, is COVID in hand in Western New South Wales?
Mr. McLaughlin.
Yesterday we had our first day of 0 cases since the 10th of August. So a steady decline in COVID cases over the last 4 or 5 weeks. It's certainly in better control than it was a couple of months ago.
And Indigenous vaccination rates in Western New South Wales, what are they up to now?
They jumped significantly. They're around 10% lower than the whole population vaccination rates, but there's a lot of effort going in across the Aboriginal medical services, GPs, their own vaccination teams to improve those across all the communities in our region.
Okay. Thank you, Mr. McLaughlin.
Can I just say on that question, well done to the team in Western New South Wales and Scott McLaughlin and all the Aboriginal, all the health workers, but having seen the work that the Aboriginal health workers were doing out there, actually going and door knocking in some of the very small communities and sometimes multiple times to convince people to be vaccinated was quite incredible. And Mr. Scott, I'm sure you would be delighted to know, as we are, that the percentage of Aboriginal people in New South Wales who are vaccinated pretty well leaves the entire country for dead. And I don't know, have you got those figures, Susan? Could you just recount? I think the percentage in the ACT, but keeping in mind the whole population of the ACT is only about as big as the Northern Beaches of everybody, so that really doesn't cut it. But compared to every other state and territory, the rate is just amazing. Susan?
Thanks, Minister. Mr. Secord, we've put a lot of effort into our Aboriginal vaccination rates here in New South Wales. Pleasingly, whilst we've still got more work to do, the first dose rate amongst our Aboriginal population is now almost 83%. Victoria is very similar to us now. However, we have an Aboriginal population here around 4 times the size of Victoria. Tasmania is doing quite well at 73%. The Northern Territory is at around 62%, Queensland at 52%, South Australia at 54%, and Western Australia at 43%, their first dose rate. So we've, as I said, it's been a concerted effort. The district chief executives, metro and rural, have really worked hard on this, and we will continue to do so.
Thank you. Thank you, Ms. Pearce.
Oh, quite useful.
If I may, Chair, if I could just, whilst we're on the topic of vaccination, Mr. Secord, in response to your first question about our rates compared to other countries, I think I answered your question, said 72% on whole of population basis. That figure is correct. It's actually 72.4%. For New South Wales, but I think it's worth noting that that's 8 percentage points higher than the rest of Australia. It's 7 percentage points higher than Israel, 15 percentage points higher than the US, 5 percentage points higher than the UK. So we're doing quite well on that whole of population basis, and it's the same as Japan. So there are other countries that are higher than us. But on a first dose basis, we're getting close to 80%, even on a whole of population basis, so those rates will come up substantially. And as to the matter of Kudos Bank Arena that was taken on notice, they've performed over 365,000 vaccinations at that stadium since it opened in early August.
Thank you.
Thank you for that information.
When it comes to
Mr. Pearce.
COVID and to making sure people are vaccinated, New South Wales is the premier state.
Minister, I wanted to return to the question of long COVID, which Ms Fairman raised with you earlier. I asked some questions about this during one of our our public accountability inquiry hearings into COVID, and it said that, and in response last night, we heard that New South Wales has not yet modelled the long-term impact of chronic disease as a result of COVID-19. Have you started that modelling process, or when will you start that process?
There's a lot of work going on, as you heard, with the communities of practice and the clinicians, so I'll actually refer that back with the Secretary's agreement to Dr Lyons.
Thank you, Dr Lyons.
Thanks, Minister. So in terms of modelling, I'm not aware that there's been any modelling done, but what is being looked at very closely is evidence internationally around the incidence of long COVID and the extent to which that is likely then to be an issue for us in our context in New South Wales with the rates of infection that we've seen and the need for us to organise our services around that. So our clinicians will be looking very closely at the international evidence, and then depending on our rates of COVID infection here, we'll be looking at what we need to have in place to ensure we've got the services appropriately configured to provide that support. I mean, we've had the blessing of having much less COVID active in the community. While we've been impacted, it's been by international comparisons on the low side, which is a positive thing. And what we'll need to continue to monitor is the extent to which even being infected with COVID once vaccinated, whether there are long-term sequelae from that infection process as well. It's unlikely, given the vaccine will provide a lot of effective coverage in response, but we'll need to monitor that as well. So in answer to your question, not aware of modelling, but we're looking at the international evidence and we're configuring our services based on our incidence of COVID in New South Wales.
So, Dr Lyons, I also asked some questions about the specialists that were available for rehabilitation. And again, it said that the answer was not very clear. Sorry, that was from the previous hearing, the previous public.
Was that a question on notice, was it?
It was a question taken on notice.
All right, okay.
Around how many specialists do you have working across the state? Are you now aware of how many specialists around rehabilitation from COVID you have working across the state?
I'll have to take that. If that's a question on notice from before, I'm sure we're working on the number. We have a significant number of respiratory clinicians working in acute COVID. Then we've got a number of rehabilitation medicine specialists who are working in recovery from COVID. But the exact numbers I don't have for me at the moment.
Okay, can I just flag that the response came back and I asked for a breakdown by local health district. The local health district answer was local health districts change the nature and the shape of their clinicians to cope with local requirements. Can we actually get some numbers, some hard numbers behind how many rehabilitation specialists?
But I think that's part of the problem, because depending on the day, there may or may not be a lot of cases that actually require that sort of rehabilitation. So you can imagine that rehabilitation specialists will be straight back into looking after the vast majority of the community who need just general rehabilitation. So it's almost a who is working on the day and is it really relevant to what's happening tomorrow? So it might be a bit hard, but look, we'll ask them anyway.
What we're particularly interested in, especially, and I know we have Mr McLaughlin on the line today, that we're particularly interested in parts of New South Wales, especially regional New South Wales, that have had relatively high rates of COVID, that will be facing these challenges, and particularly we've seen through the inquiry into rural and regional health, they've had real issues with recruiting staff. We'd like to know what the current capacity is within the LHDs for this rehabilitation services and what's the future planning for it.
It's the same issue that I just addressed, but anyway, we'll try. Can I just say it's always been, I know obviously I'm following the regional committee, but a lot of those issues have been there well and truly during the 16 years of the Labor government and the previous coalition government and the previous Labor government. It's always a challenge to get specialists into regional areas. Quite apart from anything else, if they don't have the number of patients to keep up their expertise with a particular problem, then obviously a specialist wants to maintain that expertise. And that's why we've looked at trying to ensure that through a range of issues, for example, with stroke service, Courtney, if you had a stroke a few years ago in Dubbo, there's a good chance you would have had a permanent disability, whereas the $27 million stroke service, the telehealth stroke service, now allows a specialist or two across the country, across New South Wales, to be contacted with all of your vital signs and all of the tests that are done, and they can make a decision to give you a clot-busting drug, even though they're not there in Dubbo. So there's a lot of changes that have occurred as a result of technology to try and not stop doctors going there. If we could get them there, we still would. And it wouldn't matter if it was a Liberal government or a Labor government, you'd try and get them there. But if you can't, then the next best thing to have is obviously those telehealth services. So it's not changed a lot.
Okay. Minister, on Friday at the ICAC, we heard evidence and phone taps, and one of the ones said that, there's a direct quote here, "I've already got you the Wagga Hospital. I just spoke to Dom, then the Treasurer, and I said just put the 140 million in the budget. And he said, no worries, he just does what I ask him to do," end quote. And then later, Mr. Maguire says to the then Premier, "Can you text Brad? Because I've now got you the 170 million, which he corrected from 140, in 5 minutes, and you at least can get a few extra 100,000 from Brad," end quote. Now, since that evidence has come to light, has the department reassured itself, checked, to ensure that all protocols and procedures were followed involving the allocation of funding to Wagga Base Hospital in Tumut? And I think that's...
I'm not going to comment specifically on ICAC hearings, but what I will say is that there is never a time, in my time anyway as Health Minister, where a decision has been taken other than on a substantive basis of what the population needs are. And I've worked with, as I think I said in a press conference on Sunday morning, and you'd know this, Walt, you've been in Parliament long enough to know this, you're a shadow minister, and you worked in a Premier's office, I recollect.
I did.
You did, yes.
I did.
And you would well recollect that there are processes in place that allow community members, for example, to raise issues about what the medical services are that they need, for local members to raise issues around what medical services they need, for obviously members of Parliament, ministers, other ministers, and there are processes that are then undertaken. Okay. And it's quite proper that everybody should be able, that's democracy. I don't know that ICAC fully understood that, but it's democracy. And that's the way it works. And,
are you carrying to reflect, Minister, are you carrying to reflect on the ICAC? I mean, you said you weren't going to reflect on the ICAC proceedings.
So I wasn't a comment.
Then you've just made a specific comment about the ICAC proceedings. Would you like to clarify what you're doing?
Well, I'm just saying what I feel like saying at the moment, Mr. Chairman.
So you're just simply freewheeling at the moment, eh?
I'm answering the question.
Right.
Is that all right?
Yeah, I'm just trying. You said, Minister, at the start you weren't going to you specifically, in response to the question, said you weren't going to deal with the ICAC proceedings and comment on those, and now you're specifically commenting on the ICAC proceedings. So I'm just trying to clearly understand what you're doing.
I'm answering the question.
Mr. Chair, to assist, my question actually comes back to, Minister, has the department reassured itself, like a paper audit or an audit, internal audit, that after the revelations were made at the ICAC of the phone taps, did the Director General comfort herself that all comfort herself that all procedures and policies were followed after hearing the evidence?
If you're asking the Secretary that question,
yeah,
rather than me, then I will ask the Secretary to answer that question.
Thank you.
Madam Secretary, would you like to answer the question?
Thank you, Mr. Minister.
But just before we proceed, are you very clear what the question was?
Well, it's to the Secretary now, so...
No, I'm saying to the Secretary, are you very clear about the question being directed to you?
I will speak in generalities that we are confident we have stringent processes in place for any capital development across the state.
So that's a general statement, not a specific answer.
We do
and then my
do
question
clinical
goes...
services plans, and the clinical services plan is the foundational element to ensure that we build what is necessary and what is appropriate.
We're talking about the Wagga Wagga Hospital here.
But she's answering that. What she's saying is, it doesn't matter whether it comes from a Labor member or a Liberal member or a community member. At some point, the proposal would then be considered through the clinical services planning, and the clinical services planning is done by generally the physicians who are involved with the hospital, but sometimes it goes outside the hospital to
Community consultation.
to a broader community consultation with other members of the community and physicians. If the clinical services plan is put together, then finalised by the local health district, it then goes to the ministry, has nothing to do with me, absolutely zero to do with any politicians. It goes to the ministry makes the decision on whether or not they agree with the clinical services plan as a part of the broader network of the health system. Then what happens is, if that's ticked off, it then goes to the master planning stage, which is put together largely by Rebecca Walk's team, the health infrastructure team.
And a business case developed.
And the business case is developed for that. And then, if it's all approved through all that checks and balances by the bureaucracy, then it comes to the Treasury issue of whether or not there can be a money allocation. Will the money allocation be available in the short term? Depends entirely on availability of funds. There is normally a 4-year forward forecast which is made public in terms of allocations of funds. There's also a 10-year plan which is not generally as made public, because it's not, I mean, it's where we might get to. And that's been through the Labor government and the Liberal government. And it's all done with the appropriate checks and balances. So I have absolutely no doubt that all of the decisions that have been taken, both in regard to Wagga and to every other hospital project across this state, have been done in absolutely the right way.
My time is expired.
Deputy Chair.
Thank you, Chair. I know we've already sort of talked a little bit about regional and rural hospitals, particularly around COVID, but an organisation, People with Disability Australia, has stated that they are particularly concerned about the impacts of opening up regional travel will have on the people with disabilities in regional communities who are obviously at a greater risk. I'm just wondering what's being done specifically to protect these people.
Thank you. Look, I think I think we've all said it, actually everybody said it, that this virus knows how to target the most vulnerable. And by that we mean that the people who are often in situations such as people with disabilities, such as people who are in poorer circumstances, people who are living in multiple numbers in houses, refugees and so on, it actually really has targeted them in a sense. And so everything New South Wales Health has done and the government has done is try to make sure that we put in place the appropriate resources. You probably remember, Emma, that in the start we had this 1A, 1B, 2A, 2B program that was put out by the national government, and it was to apply off the back of National Cabinet to the whole country. And that actually identified who would be doing what in the early stages. And of course, people with disabilities, particularly because of the federal government's responsibility through the NDIS, were in that category. Aboriginal people were included in that category. There are a number of different groups that were actually allegedly going to be looked after and to be vaccinated by the federal government authorities. I have to say it was didn't quite work out that way. And as we just heard a little while ago, some of the Aboriginal communities across other states and territories are still way behind the 8 ball. So in the end, what the New South Wales government did was we decided that we wouldn't wait. We just wouldn't wait. We would get out there and do what we could. People with disabilities do present some other challenges in the sense that I think there's more than, and look, the disability area is not my area, but obviously I have a real interest in trying to ensure that people with disabilities get vaccinated. But the challenges I think that the federal government were finding, and we found, were that there's more than 2,500, for example, group homes. And so it meant that there had to be them setting their teams out. Very early on, actually, we were telling the peak groups that if you can tell your various organisations that if they can get a bus, for example, and some people with disabilities, I mean, obviously there's physical disabilities, cognitive disabilities, range of disabilities. If people can come to our, for example, just as an example, the Sydney Olympic Park Authority, they don't need to necessarily come into the main area, and we set up an area out the back so that the bus was right nearby and they could come in and get their vaccines, or we could actually go into the bus and vaccinate them. When I say we, I mean the health, obviously, people, not me. And so we've done a lot of work to try and do that. I think where we're at now is that that work continues, but the federal government is also doing quite a bit of work in that front. They employed a number of different private providers to go out and to vaccinate them. What was the date of that letter you got, Emma? How long ago was it from the...
I actually don't have the date on it. Sorry, I don't have that with me. But
because I think they are really getting a long way. But which one of my team?
It's not so much about. It wasn't so much about the vaccines. It was more about their concerns once that regional travel opened up, and so people with disabilities in regional areas.
That they aren't vaccinated, so they were worried that if people go out there who are unvaccinated, that if their particular residents, if there's a resident with a disability who is not vaccinated, that they'll be exposed to that situation, I would assume.
I think that's part of the
I'm happy to comment on
Ask
that.
Susan Pearson.
Thank you.
Just to make a broad comment, however, the rates of vaccination now in rural New South Wales are actually higher overall than they are in metropolitan New South Wales.
Do you have that data?
I can produce that for you, but
Okay,
yes,
thanks.
so certainly the first dose rate in rural New South Wales is up around 93%. Which is excellent, and they've done an exceptional job. With regard to people with a disability, the current information I have is that 83% of all NDIS participants over 16 years of age have had their first dose.
What was that?
83%. Almost 86% of all NDIS participants living in disability accommodation have had a first dose. 87.5% of all NDIS participants living in a residential aged care facility have been vaccinated with the first dose, and about 88% of all NDIS screened disability workers have received at least one dose. So there is quite a high rate, and that rate has come up substantially across the disability sector, a combined effort with the Commonwealth Government but also our health services.
If we suddenly see a significant number of hospitalisations, for example, from COVID in those regional and remote areas, is that something that would be reviewed further down the track if something was to change?
I gather what you're suggesting is the causation for that. You're suggesting
if there's an increase in hospitalisations, if there's an increase in hospitalisations, would the travel to those areas be reviewed further down the track?
From Sydney, is what you're saying.
Yeah, or from anywhere, I suppose.
Look, I think it's fair to say everything's under review, but you just heard the stats. The stats are that the regions are now very well vaccinated. So I would think the likelihood is very remote.
Thank you. I am going to move on from COVID. I know we've spoken a lot about COVID, but obviously you are the health minister and your folder is much broader than that. I
would be most grateful for any question that goes beyond COVID. That would be good.
Earlier this week, I was actually speaking with the Minister for Agriculture, Adam Marshall, and I was talking to him about the issue of animal hoarding.
Animal
hoarding.
Hoarding.
We were talking about it in regards to the sentencing and the issues that obviously the courts and the RSPCA are having in regards to animal hoarding cases that end up in front of the courts because it's got nearly 100% recidivism. It's often tied in with quite severe mental health issues, and so fines and jail time, for example, aren't necessarily appropriate sentencing for people who are involved with animal hoarding. And I was talking to him about a review of the sentencing in regards to animal hoarding, and he actually suggested that it would sit more better actually in your portfolio than his. I don't necessarily agree with that myself, but I just wanted to know what your thoughts were in regards to that.
Can I perhaps for clarity's sake, the issue of animal hoarding, the Minister was, I think, a little bit surprised by the question, so I'm not sure the definition of what it essentially is, perhaps just for the benefit of everyone.
Thank you, Mr Chairman, because I must say I was just wondering what animal hoarding is.
Right. So, obviously it's very similar to the more broad definition of hoarding, so actually having too much of anything. But what happens often in animal hoarding is somebody could have 100 animals living in squalor in their home. And so they will continually collect more and more animals and keep them usually at their property. But it's usually tied with a belief that they might be the only person that can provide that animal with the proper care. But when an organisation like the RSPCA gets called out to one of these places, there could be animals that haven't had proper veterinary treatment. There might be animals that have deceased on the property, and usually the animals are living in squalor. There's usually feces all through the house, for example. So that's a classic sort of hoarding issue. It's a little bit more complex than obviously what I'm explaining here to you today. But I guess that the issue is that because there is a mental health section associated with it, that the current Protection of Cruelty to Animals Act, where people are being charged for animal hoarding, isn't suitable.
I'm starting to wish you had some more COVID questions for me. I'm sorry.
It is complex. I guess and I haven't sort of asked a very direct question either. I guess what I'm asking, I suppose when I spoke to Adam Marshall about it, Minister Marshall, the Minister for Agriculture about it, he was sort of referring it onto your portfolio, and I guess I was wondering whether you felt that something like a sentencing review for particular cases like that would be suitable within the health portfolio, or whether it belongs somewhere else.
Look, I'm sorry, Emma. First of all, I'm very sympathetic with what you're saying as an animal lover, and I just don't know the answer. It has not crossed my mind that it would be something within the health purview, but I'm happy to look at the issues. I think probably, I suspect that what Minister Marshall was saying was that, and you've described it, that it's almost a mental health issue, it's a syndrome, it's something, but I just don't know enough about it. And if it is a mental health issue, well, obviously, then my response would be I would still tread very carefully and delicately because it's a mental health issue. And I'm not sure, if anything, it would have to be a law and order. What bothers me now is it sounds like he's fobbed it to me and I'm fobbing it to someone else. I don't mean to do that. I'm happy to talk to you afterwards. It's just something I can't answer right now.
That's right. Thank you.
Thanks, Minister. Kay Fairman.
Thank you, Chair. Minister, I want to turn to some of the allegations and various information that has been exposed during the rural health inquiry as well. There has been, as we were lucky to do at the beginning of the inquiry, we were able to go to various regional centres and hear from local communities, and obviously that's continued. I wanted to. The first situation that I want to talk with you about is the Leeton Hospital. So the inquiry basically uncovered the fact that the government spent $3 million upgrading a 66-bed Leeton Hospital's operating theatre. But I understand, and it was revealed during this inquiry, that the operating theatre has not been used for the past 5 years. Are you aware of that?
I'm not specifically aware that the Leeton operating theatre hasn't been used for that period of time, but what I am aware of is that the government, the New South Wales government, as with other governments, Labor and Liberal around the country, have tried to support regional health facilities as part of both the obligation to the community, but also as an incentive, at least to try, as an incentive to get staff to come into those areas. But as I said earlier, it's a real problem because I could name a whole host of regional towns where trying to get staff into those regional towns is just proving very challenging. And pick on Parks and Forbes and the maternity services there. It's a 23-minute drive between the two, and I think is Parks and Forbes in Scott's area? Yes. Well, actually, Scott McLaughlin could probably answer this to some degree more broadly in the sense of what goes on. Leeton is not in his LHD, but he would be able to tell you the problems.
Mr. McLaughlin.
Sorry?
I just
finished. Before I go to Scott, can I just say, I know talking to Scott quite a number of times as Health Minister, I was expressing the frustration that we couldn't get, for example, obstetricians to be in sufficient numbers out there to do both facilities.
But just in relation to this, right? So it's $3 million towards an operating theatre. I understand that Leeton has really struggled getting a doctor in August.
That's what I'm saying.
The Murrumbidgee Local Health District recently announced it's called off the search for a doctor or a chief medical officer. But I just wanted to put it to you because the local mayor has said that he has been told why the operating theatre hasn't been operating. One reason early on was that the wallpaper in the recovery room was the wrong type. And then another reason is that the recovery room was 11 centimetres too small. There's a range of different reasons put out there. But wouldn't it be fair to say that potentially the $3 million that was spent on this operating theatre that can't be used for whatever reason probably should have been spent on trying to attract doctors and staff to Leeton, for example? And this is just one example.
Oh, look, chicken and egg, really, isn't it? I'm sorry, health is a lot more complex than that. And if I say this, that, for example, pick a regional hospital, it's in Scott's area as well, Dubbo Base Hospital. Dubbo Base Hospital has had a small fortune spent on it. It's a major hospital. And what we have seen is that as that money was spent in a major centre where doctors want to work, that became a lot more attractive to specialists to go and work there. But if I can just take you back, allow Scott, as he's I think the only person on there at the moment who, I've got Michael D'Orenzo. Yep. Perhaps either one of those gentlemen, I'll start with Scott. Scott, maybe you could just recount the frustrations that I expressed to you about trying to get doctors to do obstetrics at both those facilities, what you did about advertising, what the response was, and then I might ask Michael D'Orenzo to also try and answer from whatever position he likes, because they're the two regional people. So Scott first. Scott.
Okay with that, Kate?
Yeah.
Scott?
Minister, Scott McLaughlin. Scott, over the last 10 or 15 years, it's become increasingly difficult to recruit in specialist clinicians into rural and remote regions. Luxembourg did extensive efforts to recruiting both GP obstetricians, now moving to a staff-employed obstetrician model, and midwives as well. That's now seeing us advertising in New Zealand, in the UK, and other parts of the world to try and recruit in the workforce we need to sustain the services.
And Michael D'Orenzo from Hunter, New England. Oh, sorry, before you move on to that, before you do that, Scott, could you also recount the conversations, or at least the result, when I asked you to go back and advertise yet again, as frustrating as it was for you to have accept that from the Minister? What was the result after you did that?
Yes, we certainly have. We've advertised time after time, both Parks Wards and our other maternity service hospitals across the region.
And it's just impossible. Michael D'Orenzo, could you give for the committee your experience, please, as Chief Executive of Hunter, New England, for those more remote communities?
Yes, Michael D'Orenzo. Yes, very similar examples. If I just stick to obstetrics and maternity as the example, we've got many cases where we've got our rural towns where GP, VMOs that specialise in obstetrics are not available any longer, relying on locums, putting ads out on a constant basis, and really looking at what we can do to actually support those communities. And the way that we're trying to address it, because we know that we put out numerous recruitment episodes trying to get these particular medical staff to go into these groups that has been failing, is to actually work with trying to use our big base hospitals as basically the platform to be able to provide outreach support into those smaller towns, enhancing our midwives so they become much more specialised, more training, and then try to talk to the community about what is the safest way to provide the service, where high-risk births would and need to be transferred probably. If you take an example of Gunnedah and Tamworth, for example, it's about 40-odd minutes by car between the two towns. They're both large towns. We can't attract doctors to go to Gunnedah, even though they're only a short distance from Tamworth. It's how do we use the expertise and the specialised services in Tamworth with outreach to Gunnedah, enhance the midwifery services there to look after the low-risk women, and then make sure that we do all the safeguards and the quality about the high-risk births. And then use our John Hunter Hospital with its major obstetrics maternity services to do then outreach to educate and provide support to some of those GPs who, fortunately, are still trying their best in some of those rural areas.
And Kate, I mean, I think it's a case of, as I said, chicken and egg. If you just give up and don't spend the money on the facilities, then that's a message that, well, okay, we're not going to try and attract doctors there. But if you spend some of the money on the facilities, particularly at a point in time, because at a point in time when that facility was done, I think there was surgery being undertaken. But in 2017, I've just got a note here that the Secretary just showed me, Leeton District Hospital at that point had an insufficient volume of referred patients to schedule regular surgical sessions, and nursing staff were unable to maintain the required perioperative skills. So it's a constant challenge. This is not New South Wales alone. This is right across every state and territory. Labor and Liberal government are struggling with this. And in fact, when I was in the US 3 years ago, I was amazed to see, not the US, sorry, Israel. When I was in Israel, I was amazed to see in the back blocks of Tel Aviv the most incredible screens and technology where two or three, but one at any one time, intensive care specialists, American-trained Israelis, were actually managing hospitals and patients across, I think it was either 63 or 68 hospitals across the US, because they couldn't get the doctors, they couldn't get the specialists. This is a problem worldwide. And so everybody is doing their damnedest. And at the microcosms of trying to support our regional areas, I will continue to put money into supporting local, smaller hospitals in the hope that we'll get some people in there.
So
particularly as we've now developed, working with the federal government, rural generalist training programs. We're doing everything possible to get doctors into those areas, and we have to be prepared to spend a bit of money on doing it.
Yeah, I'll definitely agree with that. I think we have heard almost pretty much every single hearing for the rural health inquiry.
Are you on that committee, are you?
Yes, I am.
Okay, I didn't know that.
Well, this is the committee. Well,
it is. This is the whole committee, is it?
This is, yeah.
Oh, okay.
Yeah, largely, not Courtney though. In fact, other states were offering better incentives and better money, and that New South Wales was lagging behind in terms of GP incentives. So are you aware of the discrepancy between the states? Because that has come up a fair bit.
Well, I've heard some people say that happens in some areas, but I mean, that's we're paying all sorts of money to. Can I tell you, I've actually been in places where the local mayor, because it depends on, I mean, mostly local government's very supportive. Some of them are critical, but mostly they're supportive. I remember one council mayor telling me that they had offered a doctor a house worth nearly $1 million, a property that was quite large with, agricultural land. They had done everything possible to get a doctor there, in addition to what we were doing, and still they couldn't get anybody. So, it's part of the 21st century, I'm afraid, of trying to get doctors into regional areas. But we are not giving up. We had, between COVID, I was in Dubbo at a conference up there about, I think it was the middle of this year, but COVID has addled my brain to some degree. It wasn't that long ago. And the year before, I remember I was at Wagga with the federal government and a whole group of physicians. In fact, I think Scott was there. Scott, were you at that meeting we had looking at
Honourable Courtney Usos, we're just about
we finished that, sorry.
Yeah, thank you.
We continue to try anyway, Kate, all right? We're doing what we can.
Honourable Courtney Usos.
Minister, the national target for Code 1 lights and sirens response times for an ambulance to arrive within 10 minutes of the call being placed. New South Wales has been the second worst performing state in the country, and we haven't met that benchmark for 10 years. When do you think we will?
I think New South Wales Ambulance actually has a median response time of about 8.5, 9 minutes, something in that range, which is under... Sorry?
8.3.
8.3 minutes, according to Susan Pearce, which is less than the 10 minutes target.
P1A, yeah.
Yep, and I think that's... I don't know what you're reading from, but that's the figures that Health have given me.
I'm reading from the Productivity Commission report that says that we have not met it and only Tasmania performs worse than us. Can you explain, Ms Pearce, why we have different figures?
Can I just say, I think Ambulance has done an incredible job in the most difficult of times with Parliament, with COVID. I want to thank all of the paramedics who have worked, as a couple of them told the Premier and I on Sunday morning, the last couple of years working flat out under full COVID PPE, personal protective equipment, has been very challenging for them. We are the biggest jurisdiction in the country. We have more ambulances, more aero services and more paramedics than any other state in the country. And we continue to do what we can. We've employed over this 4 years another 750 paramedics and another 130 last week interns, which I attended their graduation. And thankfully, many of those will stay on, hopefully permanently. Working with the unions, certainly the HSU was very supportive of the 750 paramedics, but obviously I share their view that if we can get more along the way, I'll argue that case with Treasury. But do you want to add something to that?
And Minister, let me be clear, this is not a reflection on the work of paramedics, which is incredibly important, and I too acknowledge, as my colleague did at the outset, of the incredibly important work that they do and the difficult circumstances. I'm just asking about response
I wasn't suggesting
times.
you were being critical of that at all, and I understand what you're asking about, so that's fine.
Ms. Pearce?
Ms. Pearce, do you want to add anything to that?
Ms. Hutos, obviously ambulance response times are very important to all of us and our community. Priority 1 is a very large category that includes the most urgent, as well as, a lower triage categories. The Priority 1A, even in the last BHI quarterly, so that's the most serious of the Priority 1 code, was at 8.3 minutes, which is well within the 10-minute benchmark for that is used.
So just to be clear, you're talking about Priority 1A, whereas
Yes.
I'm asking you about all Priority
So there are
1.
a very significant amount of factors that go into ambulance response times. Obviously, geography plays a part. The number of calls, you'd be aware obviously that there has been an increase in ambulance calls, and they were very busy, particularly prior to this latest outbreak of COVID.
About 990,000 responses just in the last year.
I do recall the head of ambulance saying that it was like a New Year's Eve.
Yeah.
Indeed, yes. So
And I
it's
appreciate that.
been incredibly busy, which is why the additional resourcing to the service is important, and that has been. And there, in this term of government, as I recall, there were an additional 750 paramedics and control centre
Minister
staff.
just outlined that. I'm just interested then to know, if you're talking about Priority 1A,
Yes.
what are your figures for all of Priority 1?
I don't have those in front of me, Ms. Husos. We'd take that on notice.
Take it on
Thanks.
notice.
Certainly. Okay.
But can I stress again, part of the challenge here, Courtney, is that, for example, if you're out around Pitt Town, out west there, to try and get an ambulance there in some of those more remote parts of even Sydney, it can be difficult. If you're an hour and a half, 2 hours away in the regions, and I've just come back from a tour out, a couple of months ago, 6 weeks, 8 weeks, from the northwest and New South Wales, it's a couple of hours between towns at the bare minimum. So you really have to look at the fact that we have a very big state, probably more analogous to the northern parts of Queensland and to WA. It's a challenge. Having said that, obviously, always happy to get more resources.
Okay, well, let's talk about, I appreciate those challenges of geography, and I grew up in the country myself, so I understand those challenges. But, Minister, let's talk about Sydney itself. In Sydney, there are huge disparities between what part of Sydney you live in and how fast the ambulance will get to you. So for the southwest, they're waiting 39% longer for an ambulance and 23% longer, even with a life-threatening case. Minister, what are you doing to address that disparity?
Well, there's been new superstations that have been developed. I put a lot of money into that. There's been 2 programs, I think, in total around about $230 million building new ambulance stations just in the city area, setting aside the regional aspects. And I know I've attended openings of new superstations in southwest, including Bankstown and other areas across Sydney. So a lot of work's going into both. There's another. I think we're just training another 250 or converting another 240 paramedics as intensive care paramedics. There's a host of new ambulances, new superstations. We're doing everything we can to try and address those issues.
Well, let me ask you about those intensive care paramedic ambulances. How many did you purchase? I understand you recently purchased a number of new
Look, I can't remember. Can I take that on notice? I don't remember. Does anybody else know? I can't remember. No, I can't remember. There's a lot.
Okay.
And they've all got the new Lucas devices in them too, and all the new facilities for actually carrying COVID patients. So they're all world class.
Yes, and I'm just interested to know how they were allocated across Sydney. So perhaps you can provide on notice then.
Well, I can
how
tell you it
many-
had nothing to do with any political aspects because I don't know where they were allocated. They were allocated by health in the normal processes.
Okay, and so Minister, then can you then provide a
Sure.
breakdown of?
Yep.
I
I'll ask
understand there's
ambulance.
6 metro zones across Sydney.
Say that again, sorry.
I understand there's 6 metro zones across Sydney. If you can provide me with a breakdown.
I will
of
ask
those.
ambulance to do that for you. Yep, sure.
Okay, and perhaps then, Ms. Koff, are you able to tell me what the basis for that allocation was?
We take the advice, obviously, of Commissioner Morgan, who's the Chief Executive of Ambulance, and also we intersect that advice with the population demographics and assessment of the response times.
Okay, so I understand that that the intensive care paramedics, they actually work in teams of 2. Is that correct?
I'm not sure of their
I don't think they're
operational detail.
always. I don't think that's necessarily right because I think that I think they aim to, but I think I've certainly been out on the roads and seen an intensive care paramedic with a non-intensive care paramedic in an ambulance. So I'm not sure they're always allocated that way. I would assume it depends on staffing availability.
Okay, so, but Minister, I understand that well, it makes sense that the intensive care paramedic ambulances would be matched where the intensive care paramedics are. Is that correct?
Yeah, I guess. Yeah,
Okay, so
that's certainly my understanding anyway.
yes. Okay, so the Sydney Northern Zone has 10 intensive care paramedic ambulances and crews, whereas the Nepean, Blue Mountains and Western Sydney regions combined only have 8.
I don't know anything about that, but I'll find out. As I said, we'll get the numbers for you.
Okay. Perhaps you can provide then what the population comparison is between those 2 particular areas?
Sure. Look, I think, why don't we ask ambulance, and I'd be interested to know too, because that's an issue that ambulance manages, where these ambulances are and on what basis they made those decisions. And I'm happily share that with you as they tell me.
So I specifically would like to ask about Cogra because they have 4 intensive care paramedic teams doing 12-hour shifts, but they only have 2 intensive care ambulances. Is it true that you were 2 short and you didn't allocate those to Cogra?
I'm sorry, that's entirely a matter for ambulance. I'll find out from ambulance and let you know.
And perhaps then if you can say, yes, if you can provide on notice, if there are other intensive care paramedics working across the state without these new ambulances, where they are located.
I think there would be. I mean, I don't know the answer specifically, but I think in some areas, I know I've spoken to paramedics in the bush, and some of them don't have in the intensive care ambulance facilities, but they're still obviously able to do the work of an intensivist. They just don't have all that equipment. It depends on where they are.
Do you know how many are now working across the state? How many intensive care paramedics?
Can't tell you. I'll find out from ambulance, take it on notice.
Okay, thanks.
Minister, I'd like to return to, Courtney, is
Yeah,
okay?
I'm done.
Minister, I'd like to return to COVID modelling. Back in September, the Barnett Institute modelled that we would have 3,434 people in hospital, 947 people in intensive care with COVID by the start of the first week of November, which is where we are now. Thankfully, that's not the case. Instead, we have 302 in hospital, 64 in ICU today. Thankfully, it is different. So, how is or why is the Barnett Institute modeling so off? And how much is the state government, and what are the financial arrangements? What is the state government paying? How much are they paying the Barnett Institute for that?
It's called the Burnett, actually, not the Barnett.
It's my accent, sorry.
It's a good excuse. Look, I don't know the answer to that, but I don't think we actually pay them to give us that information. I think the Burnett is funded through a variety of sources, and they give the best modelling. But I think it's fair to say, Walt, that modelling is only as good as what the inputs are, and inputs are very variable. I remember, I think I've said this to you before, that last year, in about March or April, I sat on the top floor of 100 Christie Street, which was the then health headquarters, and was horrified to hear that we were going to have 25,000, or the modelling was showing we could have 25,000 people, 25,000 people dead by the end of the year. And lesson number one in modelling, well, what data were they using? Well, because we didn't have many numbers at that point, they were picking up certainly towards about late March. I think we got up to over 200 cases a day by around about the 27th, 29th of March last year. But they were basically looking at figures that came off overseas jurisdictions. So Italy was, you might remember, aflame with COVID.
Yep.
Lebanon and other jurisdictions. So it depends a bit on what the modellers choose as being their data inputs as to what you get. But the good news is, obviously, I mean, they did their best. They're researchers, and I'm not a researcher.
I can offer a comment, Mr. Secord. When the modelling was done, and you'd be aware that there was a range of modelling. Burnett Institute was one. We do our own, the Doherty Institute. So modelling, as the Minister said, is as good as the inputs that are put into it at the time. When that modelling was done, New South Wales was below 40% double dose. Mm-hmm. And whilst the model took into account vaccination, it couldn't have accounted for the speed with which we achieved the rates that we did. So in August, you'd be aware that we received 530,000 Pfizer doses from the Commonwealth. New South Wales Health alone performed close to 1 million vaccines in 3 weeks after that modelling was done. And so the effect of vaccination, in addition to the other test, trace, isolate measures that are in place, significantly reduced the impact of what was predicted. Mm-hmm. And so that is one of the explanations as to why we did not see the number of cases that were predicted. Our job, however, as we said publicly at the time, is to prepare for the worst. And so on that basis, we were comfortable with releasing that information because we needed to let our community know that in the event that the cases reached that volume, we could manage that.
Right. Courtney, do you have a question? Or can I? Okay. Earlier this year, there were concerns expressed about a lack of vaccination supply to the Central Coast and Newcastle Hunter area. They're
awash with vaccines.
They're awash with vaccines.
We are awash with it. The entire state is awash with it now. Obviously, there were constraints coming because the federal government did their best, but there wasn't the supplies that we would have liked early on. But we're awash with it at the moment. So there's no reason why anybody who wants a vaccine at the moment can't have it.
So there's no excuse not to have a vaccine. When you say awash, in fact, are we at the situation where vaccines could now go to waste?
Yes, absolutely, because there's a use-by date. So who'd like to comment on that out of my team? Who's the best?
We have worked very hard to make sure that vaccine does not go to waste. Yep. Obviously, that is the last thing we would want. We're particularly concerned, obviously, around making sure that people come forward for the boosters because, as the Minister has indicated, that despite our supply challenges during the course of the rollout, we no longer have that issue. We have told the Commonwealth, for example, not to send us more doses until we're ready to receive them because we have sufficient supply presently.
When you say to us, you mean
New South Wales Health.
Not to GPs and pharmacists, because that comes from the feds.
And the GPs similarly are managing that very carefully. So we were required to report any wastage. We've managed that very carefully, and we would move doses around, for example, if they were going to expire.
In our system,
in our
not
system.
in the GPs and pharmacists.
But I will note, just for the record, that at the present time, the Central Coast has a first dose rate of over 95%. And the Hunter areas, and there are obviously a lot of LGAs in that area, but, looking at a few of them here, Dungog over 95%, I think they certainly have lifted their rates considerably. Newcastle's presently at 93.2%. First dose. So there's no question that at present, and places like Muswellbrook, for example, we required to put a lot of effort into certain areas that were a little bit lower. They're now over 95%.
On that note, what about places like Mullumbimby?
Yes. Very happy to report about that part of the world. We've clearly been focused on those LGAs. Byron presently, the LGA of Byron, is getting up toward 85% first dose. So it was a little lower than some of the others and has taken quite a bit of concerted effort both from the local health district and from the GPs and pharmacists in that area. I think they've done an exceptionally good job.
So, Ms. Pierce, you must actually find it a bit frustrating to go from a point where earlier this year we were scrambling, we were desperate to get vaccinations, to get supply.
I couldn't possibly comment, Mr. Secord.
Well, how about you, Brad? I'll throw you a Dorothy Dixer here. You must be quite frustrated. Earlier this year, you would have scrambled to get vaccinations for New South Wales, and now we have a situation where, in fact, it could go to waste that we have, as your own words were, awash with vaccines. It must be quite frustrating, the lack of coordination at the federal level in this regard.
Thank you for the opportunity to speak on that issue, Mr. Secord. All I'll say is I'm delighted with how we are at the present time.
Thanks very much, Minister. I was talking about ambulance waiting times earlier. I'd like to now move to emergency department waiting times because there is a clear disparity here as well between where you live in Sydney. For example, if you're a T2 emergency case at St Vincent's, you'll be triaged within a minute. But in comparison, the latest data shows us that Blacktown was 18 minutes or Nepean was 17. What are you doing to make sure that residents in Western Sydney are receiving the same level of care as those in the east?
We are doing everything we humanly can in terms of both money and staffing. The challenges, again, in health are much more complex than your question perhaps portrays. For example, in southwestern and parts of Western Sydney, the community which is very multicultural, don't necessarily have an understanding or they don't have experience of going to a primary health provider. So, for example, I'm not going to name the countries, but there's a whole series of countries where GPs are just not available. So they tend to use the emergency department as a GP practice. And that does create issues for us. And we try to do everything we can to educate people, but at the end of the day, our health system will still accept people in through the EDs. And that does create issues. And it's been compounded by the COVID situation the last couple of years. But why don't we we'll ask Graham Lloyd to comment on that, or who would you like to comment?
I can make a comment.
Susan Pearce can give you the ministry
at an overall rate, Ms. Hughes-Hoss. And look, there are complexities, as the minister's noted, in regard to treatment on time performance that you're talking about. It's very difficult to pull one figure out from one hospital and compare it directly with another because there will always be different factors. There's certainly a lot of work that's gone into treatment on time because it's critically important that people are seen and triaged in the appropriate category. And so, for example, Wollongong was one hospital that put in place a rapid assessment process to ensure that people, move through more quickly. But just as an overall comparison, because you're drawing a distinction between east versus west on this, overall southeastern Sydney has a lower rate of treatment on time than southwestern Sydney. So it is easy to pull out one hospital and compare it to another, but if you look at overall rates, it's not quite as simple as that.
Perhaps you can provide that on notice.
Happy to.
My time's expired.
Deputy Chair.
Thank you. And just to clarify as well what I was talking about in regards to hoarding before, in our office, we're looking at switching the model so that if somebody is an animal hoarder, rather than facing fines and jail time, that we're really looking at things like counselling and changes like that. So that's kind of where that discussion was headed. I realised I didn't clarify that either when I was telling you about their work in that space, but we can take that offline and talk about it further if you're still open to doing that.
Yeah, no, happy to.
Wonderful, thank you. I'd like to talk about...
what do when Parliament's on next... Was it next week or the week after?
Yep. We're sitting for 3 weeks.
Just come upstairs and we'll have a chat. Yep.
Sounds great. Thank you. I want to talk about endometriosis as well, which is a very painful condition experienced by many women. And it still takes 7 years on average to get a diagnosis of endometriosis. New South Wales obviously has the largest population, but as such, they also have the highest number of endometriosis patients. We've got 260,000 endometriosis patients and counting. The first national clinical guidelines for endometriosis have been released to actually help GPs to diagnose and to actually reduce that length of time for a diagnosis. 7 years is obviously a very long time to be pain and suffering, and also to obviously be able to treat that condition earlier. However, Endometriosis Australia says that further work still needs to be done to make sure that GPs are actually aware that these guidelines exist and to start using them. Is this something that New South Wales Health is assisting with, or is it something that New South Wales Health is willing to assist with?
Endometriosis is a huge, huge issue for, as you said, many, many women, and the diagnostic capacity principally lies obviously with GPs in most instances, because most women would be going to see their GPs, but certainly we get, as I just said to Courtney, we get women who, particularly in some of those areas where they don't have a history of GPs, they come into our emergency departments. Emergency departments, of course, are there to deal with emergencies in the sense of they don't necessarily deal longer term with issues that in the case of endometriosis would generally be a much longer term issue, but they can exclude emergency requirements. And of course, quite often onward referrals to appropriate specialists to deal with the issues. I don't know whether any of the people online are actually got the expertise in that. Does anybody?
Nigel deals with the GPs.
Okay, that'd be fantastic.
I'll ask
Dr. Lyons.
What, can I see him? He's disappeared.
So thanks for the question. So as the Minister said, endometriosis is a condition which is primarily managed through primary care and general practice. But what we do in the New South Wales health system is provide guidance and support to GPs, often through the establishment of what I call health pathways, which would give advice through the local health district teams of specialists and the GPs within our primary health network around what investigations are available locally, who to refer a patient to who might be suspected of having endometriosis, what investigations need to be done before that referral is made, and what can be done to support ensuring that people get access to high quality care and the diagnosis is made and appropriate treatment offered. Those arrangements are often put in place through discussions between the local health district specialist teams and the GPs and the PHNs, and they're very useful in providing that support. So while the national guidance has been developed and has been communicated, our challenge always is how do you get that through to the individual practitioners deliver care, and how do you ensure that guidance that supports them is actually effectively utilised. And one of the ways that we do that is through the establishment of these locally contextualised pathways for management of certain conditions. So if there's a need to do more, we would be very happy to take that issue on and start discussions through a PHN statewide network that we have. So we meet with the primary health networks right across the state on a regular basis, and we can raise issues with them that are needing to be addressed on a statewide basis, so I'd be happy to take that forward.
Can I also say that we have a number of women's health centres in New South Wales, and obviously the state government puts money into those women's health centres to support women on a range of women's health issues, including endometriosis. We provide grant funding. Some of those health centres have GPs that work in them as well. But as Dr. Lyons said, it is sometimes a challenge. The fact that a GP is qualified to be a GP doesn't mean they necessarily will be in a position to have diagnostic skills over every issue. So it will remain a challenge. But if, whatever we can do, as Health Minister, I've got to say I'd be delighted for New South Wales Health to support GPs and others to do it.
I have a little bit of additional information that's just come through, and that we also have information on our Agency for Clinical Innovation website. They've done some work in this space to provide further support. And there's also information from the Emergency Care Institute, which is the institute that's been established in the ACI that provides advice to our emergency departments right across the state. So if women do present to an emergency department, they're provided some support about what action they can take recognising, of course, as the Minister said, that they're mostly there for emergencies, and ongoing investigation and management will be back through general practice and primary care and specialists in the community generally.
Thanks, Dr. Lyons.
Thanks, Dr. Lyons. And yeah, certainly it sounds like, you know, part of it is getting those clinical guidelines to those GPs and making them aware of them. Minister, you mentioned that there was some funding in this space in the women's health centres. Is any of that New South Wales government funding going into research into endometriosis specifically?
I can't answer that off the top of my head, I'm sorry, Emma, but I can tell you there's more than $1 billion a year that goes into research across a whole range of areas. So I would imagine that some of it is being along those lines. But you just heard the Agency for Clinical Innovation has been looking at this issue. And if ACI is looking at it, ACI would almost certainly be connected with researchers who are looking into those issues as well. That'd be very... does the Secretary, she's nodding like, am I right?
What I was going to say, if I may, Minister, the National Plan for Endometriosis released by the Commonwealth had significant funding for research, $9 million into non-invasive diagnostic testing, 2.5 into research funding for Jean Hales for Centre for Women's Health. So there's a range of funding allocations that have been made by the Commonwealth that we work in partnership with them on, because a lot of them are allocated to initiatives that may be conducted here in New South Wales.
So some of that funding may have come from New South Wales. Is it? Yeah. Thank you. Could I actually put on notice how much New South Wales government funding has been put into endometriosis research and also adenomyosis?
On notice?
Yeah.
Happy to try and find out, but can I tell you, like a lot of this, it's very difficult sometimes because...
Falls into categories.
Yeah, because clinicians also do research. So you'd find that there are clinicians who are working in the area of endometriosis who are, and obviously other women's health issues, who are spending time both in clinical and research. But we can give it a go. I'm happy to find out on that front as far as we can. But just be aware it won't be precise.
Thank you. And this one might be a question for Dr. Lyons again. Adenomyosis is often described as the evil cousin of endometriosis, and even though we're still so far behind on endometriosis, it just seems that we're even further behind on adenomyosis. And I was wondering if the government or New South Wales Health have done anything to at least increase awareness in the space of adenomyosis as well.
Dr. Lyons.
I'd have to take that one on notice. I'm not absolutely clear about any specific issues in relation to that particular matter, so if you wouldn't mind, we'll take that one on notice.
That's fine, thank you. Given the pain and the length of time to get a diagnosis on this issue, it's obviously also associated with a lot of stress, and sometimes people even express depression or hopelessness. Do we have any idea of the sort of impact these health issues have on people's mental health, and what sort of programs the New South Wales State Government's supporting to help deal with that?
Look, I think, again, the support for mental health issues across the board is quite extensive. And I think you're right that I know people who've had endometriosis and it can take over your life effectively. There's a lot of work being done to support women generally in women's health issues and the consequent issues, particularly around depression, sense of hopelessness. But I can't give you the specific amount at this stage because, again, it would be mixed in with all of the other mental health issues.
Thank you. I also want to talk about dementia. So dementia is the second leading cause of death of Australians and the leading cause of death for women. And with an ageing population that's becoming an even bigger issue, what steps is the New South Wales Government taking to support those currently living with dementia?
Can I say a former Labor Deputy Premier has actually been very involved in this area, and I know, I think the forecast is it may become the leading area for deaths, in fact, in the next few years. There's been a lot of work done right across the board between the federal and state governments, all state governments, again, irrespective of political background, in terms of funding into research for dementia. I can't give you the specific figures, but I know year after year there's been an enormous amount of money spent on it. That's all I can tell you at this point, unfortunately, Emma.
Kate Fairman.
Thank you, Chair. I too wanted to go back to long COVID, just that discussion. Minister, or actually I think Ms. Coff, you may have talked about the numbers of children. I think maybe it was Ms. Pearce, I'm sorry. The numbers of children now in terms of the total.
I mentioned that about 40% of all the current cases were under the age of 20 and about half of those in the last few months have been under the age of 10.
So how many children then within the state have long COVID?
One of the good things about, or if there's anything good about COVID, is that children don't tend to get severe responses to COVID. It tends to be fairly mild. We have had, I think, 1 or 2 children end up in the ICUs, but generally it's very mild. I've had no information given to me at this point indicating that children are prone to long COVID, but I'll just check whether any of the medical people on the call have any more information on that. Does anybody, Dr. Lyons, do you have any knowledge of that, or Susan Pearce? I'll have to take that on.
I've got no knowledge about children with long COVID at this point in time, so we'd have to take that on notice. I expect them listening or anything.
Could I tell you, Kate, it has not, in all the 2 years that I've been, well, almost 2 years that I've been intensively doing this, sometimes 18 hours a day, it's never been a topic of discussion. So I don't think that it's a major issue, but let's find out for you and for me and for us.
Okay.
And I'll take it on notice.
Okay, I might put some other questions on notice in relation to that then. I just wanted to also just ask a question about the when the government was announcing, like a lot of people being in ICU and deaths and what have you. I have heard from somebody who is working in an ICU that many of the patients, a vast majority of the patients that were coming into ICUs with COVID, the underlying health condition was really obesity.
It was the comorbidities that came with it.
But like obesity was a big factor. So what's the government doing in terms of obesity prevention, which is obviously chronic disease prevention and wellness? What programs is the government doing now? And as a result of COVID, are you going to increase the funding into disease prevention programs that, of course, can help address the obesity crisis that New South Wales is certainly facing?
First of all, can I say that obesity was a factor, but it certainly wasn't the only factor. Almost invariably.
Have any stats on what the underlying
very hard to distinguish
health conditions
very
were?
Hard to distinguish, but what we do know is that majority of patients who are passing away had age disadvantage and comorbidities disadvantage, so multiple ones. For example, respiratory disorders.
But also within the ICU, Minister, not necessarily those that have passed away, but those that found those that were...
I was asked that a long while ago, and when I asked the question, I was asked by somebody, I can't remember who it was, and when I asked of health whether they could do that, what they told me was the cost would be enormous to go into every patient's medical record and try and dig that information out and to draw necessarily any conclusions when we knew that, people do need to have programs, obviously, that can assist with their, for example, as you've said, obesity. Can I say to you that the government has certainly, in my time, had quite a bit of focus on preventative work, but that's really the future of health. And the preventative work that's going on, for example, in obesity management. You might like to go and visit it one day if you want to, out at Penrith the P, and there's a magnificent service directly over the road from the hospital there that shows you world's best practice in terms of how to manage it. It's a multidisciplinary approach. It isn't just telling people how to eat, it's also all the other allied health support that you need. We have 2 of those that have been established. They're quite expensive. One's in the P and one's, I've just forgotten what part of Sydney the other one is in now, but Concord. Thank you very much, Ms Pearce. And I think there's a high level of interest in seeing what the outcomes of that are. the facility at, for example, Nepean only opened about, it was just before COVID, I think, so 2.5 years ago maybe. But we are doing a lot of work on that to try and establish whether these sort of multidisciplinary teams can make a real difference.
Because I understand there's a national preventative health strategy expert steering group, and there's a target to increase investment in prevention, disease prevention and wellness by 5%. This is government investment by 5% by 2030. The federal government has apparently said commitments needed across state and territory governments for this investment. I've also seen some of the Victorian and the Queensland and West Australian prevention programs, such as My Health for Life, which is Queensland, and WA has one called Live Lighter.
We have similar programs.
What I understand that there was a Make Healthy Normal New South Wales program, which is no longer running. Is that correct?
I thought it was still running, but okay. I don't know. I thought it was still running.
What's the proportion of the health budget that is spent on preventative health, and is there a plan to spend more, given how much of an impact COVID had on particularly those people who potentially weren't as healthy as others?
Health, it's really across a whole range. I mean, every known condition to mankind. We have community health centres located all across the state with a whole range of expertise for ambulatory care, as the physicians and the doctors, the medical people talk about it, ambulatory care. So you tend to go into those centres and you get support. They also have a lot of support for programs at home, so you can actually try and look after yourself, but given some guidance from the community health facility. So there's an awful amount of work being done on this, if only from the reason if the health system is honest, the health system can't continue to grow at the rate that it's growing to deal with acute medicine, acute responses. We need to look at other ways of doing it, and the only way really is to try and work more in the preventative space. But do either one of the secretaries or any other senior physicians, senior people want to talk on this?
The good Dr. Chant, as Chief Health Officer, is responsible for the health promotion and prevention programs across the state. Obviously, during the period we've been to, the intensity of effort on some of those has diminished because of the resources being deployed for COVID. However, we're still fully committed to prevention, keeping people healthy through prevention and health promotion, and we map that as part of our budgetary outcomes reporting to Treasury, because in reporting our outcomes of our total budget, it's important to get the balance right between acute hospital services, emergency care, surgery delivery, and the health prevention and promotion programs. So in terms of our year to date, not to be surprising, we've had a lot of investment because most of our COVID prevention initiatives have been counted in that. But we're tracking that the full year projection, 3,861 million we spend on prevention and protection.
So is there a target, because one of the Premier's priorities was to reduce childhood and obesity rates by 20% by 2025. However, I understand that Premier's priority finished in 2019. Is there a target that New South Wales Health has, or you've set, Minister, to reduce obesity either in adults or children now? Is there a current state target?
As you correctly observed, the premiers have set in recent years targets across a range of areas for the whole of government to achieve in various aspects, including obviously that in health. I think that the health system, or I know that the health system more broadly in every LHD that I visited, every local health district I've visited has programs targeting obesity. But it's probably the most challenging thing that faces the Western world. I don't think that there's any clarity around where we're going to get to, except we're trying.
So in other words, just in terms of the government's efforts, though, recognising that there was a Premier's priority finished in 2019, clearly COVID has really shone a light on the need for people to try and be as healthy as possible, but there's no state target now, and you do know that how much that does drive investment. So would you commit to reinstating another target, for example,
Kate,
for
everything
obesity?
at the moment, everything I think, again, I just had a text from one of my Labor colleagues in another state about some of the issues they're looking at. I think that it's fair to say that each and every one of us are looking at a range of issues that we need to address based on the highlighting of the most challenging areas that COVID has managed to attack. Housing is another one. I mean, housing is an issue for us all. There's a lot of work being done on every state and territory, but we've found that, again, the most vulnerable, often the lowest socioeconomic, the groups, the people in the lowest socioeconomic groups, not always, but are often the ones with housing issues, obesity issues, a whole range of other issues which make them vulnerable. So I think when we manage to get through, and I have a sense here that the committee thinks that we're out of COVID. I don't see that, and I'm still spending half my days, in fact probably 2/3 of my days on COVID issues. Still, that's the principal focus. When we get through that, we'll start getting back to some of those more basic issues.
Thank you.
Thank you, Minister. Thank you, officers. We'll break now for lunch and be back at 2 o'clock sharp. Thank you.
The government doesn't have any questions.
Yes.
Thank you.
Cheers.
You might like to see that. It's going from
Well, good afternoon and welcome back to Portfolio Committee Number 2's Health Budget Estimates hearing for the afternoon session. Before I commence, I'd like to pass over to the Minister who has got an explanation in terms of our timing for this afternoon. Minister.
Oh, thank you, Mr. Chairman. And look, I just wanted to, having in mind that the Liberal and National Party members have agreed to not ask any questions and to give over their time to the opposition and to the independent members, and having in mind that the senior health executive, which quite a number of them are actually here available at the moment, I would dearly love them to be able to deal with some major issues which we were just discussing during the lunch break. So I formally request that the time that would normally be allocated to Liberal Nationals, which would take us back to about 3 o'clock, would see this hearing actually terminate this afternoon at 3 o'clock. I can indicate that I've had informal discussions with each of the members of Parliament who are involved in the committee, and I understand that they also are prepared to accede to that request, but that's a matter, of course, for you, Mr. Donnelly, and the committee as a whole.
Thank you, Minister. Well, I think, and thank you for that and the explanation there too. There has been some informal discussion between members, and there is concurrence with respect to the request. So the proceeding now will commence and take us through to 3 p.m.
Thank you.
And at 3 p.m. that will conclude our proceedings for today. So
I thank the committee for that indulgence. Thank you.
And thank you, officers. So is everyone clear in that regard? So we'll have 20-minute tranches of questions taking us through. It might be just 4 minutes past 3, but it'll be basically 3 o'clock. So,
okay, well, put my skates on.
The Honourable Walt Secord.
Minister, in 2018, the member for Bega and then the Premier announced that a level 4 hospital would be built at Eurobodella. It's now 3 years on. What's actually happening to that? And all the community has. And the community has given its approval or consideration to a clinical services plan. So when will they get their level 4 facility?
Thank you very much, Mr. Secord. Look, as part of the focus on regional health across New South Wales, there has been agreement that in that particular area of Eurobodalla, Maruya direction, there is a need for a further enhancement of the health facilities. The clinical services plan, as I understand it, is complete, and there has been money allocated, and of course there was a press release issued some time ago in regard to the building of the hospital. I can indicate that there's also some further work going on at the moment in regard to the clinical services plan. There have been some discussions with medical practitioners in the area who've indicated that they'd like to look at some further enhancements to what was originally agreed to. That is still being worked through with health. I think from memory, I better not indicate what it is, but I know that there was some other issues. What happens is when the clinical services plan is complete, there's often a review by individual doctors who raise issues. And I know that the community down there are very keen to see, for example, at some point, an MRI facility in there. And I think they're also indicating some, this is off the top of my head, I haven't got any notes here on this, but my recollection is they're also keen to see an enhancement of what was agreed on the maternity beds. And certainly that would appear to be, in my view, quite a valid aspect, but I've asked Health to work through those issues and also indicated that if that's something which New South Wales Health agrees to, through the normal processes, then of course Treasury would be also then consulted in terms of the money that's available or necessary.
Do you understand that there are strong concerns from specialist doctors down there? I think obstetricians, that about extraordinary workloads. In fact, the Rural and Regional Health Committee, he was working now chair. I think it was more than 80 hours a week, wasn't it? 80 to 90 hours a week being on call.
You're talking about one specialist?
Yeah.
Yeah, I don't know that this is going to solve that problem. I think that that's the sort of problem that we have right across the state when we can. You heard the earlier discussions about trying to access obstetricians. But I know that the member for Bega, I think he's still a member, isn't he?
He still is.
He's still there. The member for Bega had certainly raised that issue with me on numerous occasions, and I had indicated to him that we were working through, obviously, the normal formal processes, but he's raised the issue of the need for as I recollect in his view, the increase of, I think it was an extra 4 or 6 beds, I'm just not 100% certain, in terms of the maternity unit and also an MRI. Of course, the MRIs, the licence for the MRIs are a federal government issue, as you'd probably be aware. And at this stage, to my knowledge, the federal government haven't agreed to a licence for an MRI. Long day for an MRI, but I've certainly indicated to Health that I'd like some formal decision made on the value of an MRI for that community. I believe that it's a good idea. On the face of it seems like a very good idea because it saves transporting patients who might need an MRI to the nearest MRI, which is some distance away. So all those things are being worked through in the normal process at the moment by Health, and hopefully in due course they'll be able to make those announcements.
I understand my colleague Courtney.
Has construction commenced?
I'm sorry?
Has construction commenced?
It wouldn't have. Because
I might say Minister Rebecca Walk's online from Chief Executive of Health Infrastructure.
I don't think it would have yet because it's only been announced recently. I mean, it takes a little while to get that done, but let's let Ms Walk, who's the Chief Executive of Health Infrastructure, give us the benefit of her infinite wisdom.
Come on down.
Thanks, Richard. Good afternoon. Well, the site was announced, the preferred site was announced on the 7th of December and the stakeholders endorsed the master plan earlier this year in May. We are going through the site acquisition process at the moment and we're expecting the schematic design to be completed a little later this year and some of the statutory planning processes to be in place then.
And when are you expecting construction to commence?
We are intending, following the site acquisition process, to commence early works in 2022.
I don't think you heard that question.
She just answered it though. She just said she thought that early works would commence in 2022. She didn't hear the question, but she answered it without hearing it.
Okay.
Completely? Yeah, okay,
and
that's
when
fine.
are they due to be completed?
I have to take that on notice.
Most of those, can I say, I think that hospital is more than, correct me if I'm wrong, Rebecca, but I think it's more than $200 million worth. And generally a hospital of somewhere between 100 and 250, and it's on greenfield site as I recollect. That would be at least a couple of years, two to 3.5 years to build it, and probably another few months to commission it. So generally, it's about 3 to 4 years. What's your best estimate, Rebecca?
I would say that your estimate there, Minister, is correct.
Yes, Minister. Okay.
Excellent.
Thanks, Ms Wall.
Minister, what do you say to criticism in the community that the hospital that is proposed is beyond or not up to the growth that's occurring in the community? So you're actually going to build a hospital that's too small for the needs or inadequate for the needs. Ms Walk?
I don't know that that's the case because the work that goes on in this sort of preparation is quite extensive and it was put together through all the due processes. And the clinical services plan that was put there, of course, was put there by all of the physicians. But what we do find from time to time, Mr Secord, is that when we have done all those due processes, you might find 1 or 2 doctors who would like their particular area expanded. That's not an unusual position because normally doctors in a specialty think their area of specialty is by far the most important, and that's understandable. But I have absolute confidence that the system that operates at the moment is beyond rigorous, it's exemplary. So I'm sure that what the health infrastructure people have done, working with the local health district, would be exactly what's needed.
Minister, I want to turn you to local health districts. How does one get appointed to a local health district?
I'm
not asking. I'm not asking personally. I'm asking in general.
No. Do you mean the board, or do you mean working in it?
No, a board.
Obviously, in terms of a board, the positions have been recently, maybe a few months ago now, advertised because the positions under the original legislation were that a board member could be appointed, and if there's any of the executive who wish to correct me, feel free. But my understanding is it's for up to 10 years.
Up to 10 years.
Up to 10 years. But at 10 years, you can't be reappointed at that point. So it's normally 3 to 4 years you would be appointed for. Then it's appointed with the sanction of the minister. So most of the appointees earlier on would have been appointed under the new system, would have been Minister Skinner's imprimatur.
Right.
Most of them are now mine. So, for example, we have a range of people with expertise. Each of the local health districts, we try to have a proportion, for example, of women, a proportion of people of Aboriginal background, people with finance, auditing skills, medical skills, and so on.
So
sometimes it's local government. I mean, we've had former Premier Yemmer is on one of the boards at the moment, not the local health district board, but has been, I think, from memory, but is on one of the other health boards. We've got David Campbell, who's formerly the member for Wollongong, who's on one of the other boards. We have Andrew F. Shorgie, who former Deputy Premier, who chairs one of the boards. We have quite a range of people of skill sets from all backgrounds
now,
and political colouring.
Is it hard to be... Now, what does one have to do to be removed?
Looking for a post-political job, you would have the skill sets, Mr. Secord, and you should put your application in, it's then considered by...
let's park that aside. So what does one have to do? Can you be removed from a board before your tenure ends?
Yes.
Okay. Now, I want to take you to the southern New South...
You want somebody to be removed now, do you?
Yeah, that's where I'm going. Okay.
Right.
So I'm the Southern New South Wales Local Health District Board, which is Southern New South Wales. There's 1, 2, 3, 4, 5, 7 people.
If you're going to name somebody, I'd ask you to exercise judgment in not perhaps doing that openly.
Well, no, it's on the public record. In fact, the Premier distanced himself from one of the board appointees, and this was Prue Goward when she's on the board down there. And after she wrote a piece for the Australian Financial Review criticizing poor people for a lack of discipline, housekeeping skills, and I just wanted to know, in light of the Premier's distancing from her, does she enjoy your support?
Number one, I'm not familiar with the article to which you refer. Number two...
It was canvassed in question time. It was canvassed in your question time.
Number two, if that were an issue which reflected on her judgments, I would be obviously considering that, but I've seen nothing at all other than exemplary service from Prue Goward, as I have from the other members of Parliament that I've just mentioned. Former members of Parliament.
Well, the answer
is no.
Just to assist you, Premier Dominic Perrottet in the Legislative Assembly condemned his former cabinet colleague, and he said, quote, "I completely disagree with it. I thought the entire premise of that was terrible," he said on Thursday in the State Parliament.
As I said, the job of being on the board involves certain skill sets, and if it came to my attention that somebody was not doing that, then I would, or meeting those obligations, then obviously I can terminate. But that's certainly not something which nobody except you has ever raised the issue that she might not be appropriate in that area. And I think, is she on? What board is she on? Southern, I think, is the area that she formerly represented as a member. So I feel quite confident that if nobody else has raised, not that I would ever challenge your judgment, Mr. Secord, I would consider your contribution, as I do others, but I've had nobody else mounting the argument that she should be removed.
But just to assist, there was an opinion piece that she wrote in the Australian Financial Review. It was canvassed widely. It was canvassed in the Legislative Assembly, canvassed in the Legislative Council, and the Premier disassociated himself from her remarks.
Can I say that members of Parliament are always subject to such matters, either when they're in Parliament and when they're out of Parliament. I look at the substance in terms of who should be on boards. As I've just indicated, politics is no bar. A range of views are no bar. We should contribute to the jobs that we see that we have if we're board members or if they are board members. And I've seen no indication that she's not doing her job. In fact, quite the opposite. She seems to be doing a good job. Courtney.
Minister, last year in June you announced an extra $388 million for elective surgery. Do you know how much of that has been spent?
I don't know, but I'll ask if Susan Pearce knows that.
I'd have to take that on notice.
Okay, are you able to also then provide us with a breakdown by LHD of how that's been spent?
I'll take it on notice.
Okay, thanks very much. Minister, you were just talking about clinical services plans.
Yeah.
And the one for the Eurobodalla Hospital is publicly available. It's
generally clinical services. There's no policy direction absolutely on this, but clinical service plans are done, and always have been actually, even before LHDs were created. Clinical services plans were not as a routine made public. And the reason they're not is that you have a range of people, a range of interests from the medical practitioners themselves through to members of the community who who can express their interest in the process, but at the end of the day, the clinical services plan is developed by the LHD with the approval of the board, in this case now, and the ministry. And sometimes it's not particularly helpful to have that made public, because you can find that people then start pursuing their own personal agendas. So it's better that it be done in a normal professional way, as most board deliberations are done.
But
Having said that, can I say sometimes they have been made public because of particular local concerns, and some local health districts have from time to time made those public. I've never given any direction on that. That's a matter for the local health district board to determine.
So one issue that I've asked a number of questions in budget estimates about has been the lower Hunter New England clinical services plan.
Lower Hunter...
Sorry, the Hunter New England. It's for the lower mid-north
There
coast.
wouldn't be a Hunter New England clinicals, because it's a clinical services plan for individual hospitals. So which
So
hospital?
it would be around Manning Base and would also cover Foster Tuncurry.
Okay.
So there's been repeated requests.
Sorry?
We've got Michael online too.
Yeah, sorry, Courtney, what was that question?
There's been repeated requests for that particular clinical services plan. I've asked questions about it here, and now there are calls from the community to make it public. Will you make it public?
Well, it's not a matter for me to do, but you've got Michael Diorenzo, who's the Chief Executive, who could perhaps give us the benefit of his views and the board's views up there.
Mr. Diorenzo, please.
Thank you. The view of our board is that the clinical service plan is an internal plan, and I accept that we've been asked by a few different stakeholders to make it public. Our position is still that we don't wish to make it public, but instead what we have done is I personally have gone to Manning Base Hospital and have sat down with a range of stakeholders, the community, our medical staff, the Medical Staff Council, and a range of other community members. And what we did is we presented the clinical service plan. We went through the process, the findings, and then ultimately the recommendations, which lead us then into the master planning process, as was mentioned, for the construction of our $100 million project there at Manning Base Hospital. So that's been our approach. That's the district's approach, and we've applied that across all of the hospitals and all of our clinical service plans.
So you don't release any of your clinical services plans?
No, we don't. What we do is we spend time consulting with the community, going through the clinical service plans, and also then identifying what are those enhancements to services and what are we doing about improving healthcare associated with the clinical service plan, and then describe how the clinical service plan guides us into how we design and build that new infrastructure.
And Mr.
Diorenzo.
Michael Diorenzo, Courtney. Diorenzo.
Mr. Diorenzo, so why won't you make specifically the Manning Base one public? What was the basis for that decision?
The basis is that we don't make them publicly available as part of our policy in our district. And the reasons are really the reasons that the Minister outlined earlier. We rather have the time to spend with the community to go through, firstly, the findings, and then work through the recommendations and do the consultation process. What we have made available is that if people want to have a read of the particular document, that they have access to it. What we don't do is put it on our website or on our internet or intranet sites, because it does create, I think, a lot of confusion sometimes. It's better to actually walk through it with the stakeholders and talk about what aspects that we are working on. And many aspects of the clinical service plans are really also about what we're doing about enhancing health service, not just with the new infrastructure, but part and parcel of where we've looked at health services generally in that particular community.
If you do request to see a copy of that, which I actually have a copy of an email here where someone has specifically requested to see that, and that request was refused, why would that be refused? What's the basis?
Can I add, Courtney, on that front, that they're very technical documents, and it has always been thus. There's not a lot of advantages of being as old as me, but I do remember that when Labor was in government, they were not not released at all during that period either. So it's a matter it's always been thus. And it's because it's a technical document and the community and certain people can not necessarily assist in that process. They get all sorts of opportunities. Michael, can you explain the opportunities the community have had, in your case, on that particular one that the member's interested in, to actually have an input?
Minister, I accept that they may not have been made public in the past, but...
Ever, under Labor, ever. 16 years of Labor, never.
Well, you have been in power now for 11 years, Minister.
Yeah, and we haven't changed that.
And there are clinical services plans that are available. In fact, I've had a look at the one for Eurobodalla Hospital.
Some of the LHDs feel that's appropriate.
Exactly, and there are members within the Foster Tuncurry community who are very keen to see this clinical services plan. They've raised it directly with the. I've raised it here with you. I've asked about the status of it. They've raised it directly with the LHD, and they've been told no, they won't have access to it. But Mr. Di Lorenzo has now said that they can have access to it. I'm just interested in how they can gain that access.
I think he was saying, I won't actually, I'll let you deal with it. I think what he was saying was they would take them through what is actually the result. Am I right there, Michael, or not?
That's correct, Minister.
Yeah, not actually hand over a technical document.
Yeah. Look, I think the group that you may be talking about is the same group that I spent a vast amount of time going through the particular clinical service plan with them, and also answered a range of questions which they wrote to us to actually clarify. So that has been undertaken. What we do is we have the clinical service plan available in hard copy for our clinical staff who have worked on this and need to be aware of some of the detail. And for the other community members, as I said before, the process is that they're able to sit down and go through the document and have a look at it, but we don't make it public.
Can I just clarify? Sorry.
How could they access it? You said they could sit down and go through it. How would they be able to access that?
Well, what I'm suggesting is that we have gone through it with them in terms of highlighting the executive summary, the findings, the recommendations. As the Minister pointed out, some of these documents are hundreds of pages and very technical in nature. So what we're doing is actually assisting them in actually going through the issues that they're raising, which is they'd like to know what services are being enhanced, what are some of the gaps in services that have been identified by the community and by our clinicians, and then the recommendations of how we're moving forward in implementing that clinical service plan in the new infrastructure, but also within our workforce plans and so on, in providing better healthcare in that community.
Mr. Di Lorenzo, you just said that they could look through it. How would they actually do that? Would they contact you directly? Would they contact how does someone, if they are interested, as an interested member of the community, how can they access it?
As I said, they can access it by sitting down with the general manager of the hospital and going through a presentation on what is in that particular document.
I think what he's saying, Courtney, is that what I'm hearing anyway, and I've heard this many times before from other areas, is he doesn't want to necessarily, or the board doesn't want to hand over what could be a very big document, but they'll go through what are the aspects that are coming out from that clinical services plan for the community. I just want to highlight too that we've said $100 million, but I think from memory that hospital had $30 million spent on it recently, and now there's $100 million coming through. So, is that right? I think.
Yes, Minister. We're now into an additional $100 million of investment.
Deputy Chair.
Thank you, Chair. Minister, we've spoken in the past about funding for alternatives to animal research. Are you able to update me as to whether the government has made any investments in this space particularly?
Can I take that on notice, please, Emma? Because I'm not sure
absolutely.
where that got to.
Just to give you an example as well, the University of New South Wales has recently launched a 3Rs grant scheme where researchers can apply for funding to support science-based projects with a primary goal of replacing, reducing or refining the use of animals in biomedical research. And certainly we've also met with some people in the EU that came out with a report where they're saying that there needs to be greater investment in non-animal models because they've really hit a wall, particularly in animal research, particularly in breast cancer research. Has the New South Wales government ever run anything, or would you actually consider looking to ensure that there is some funding in that space?
Specifically to not have animals involved in the research, you mean?
To look at new science-based projects which use things like, I've got something written here, but essentially with the primary goal of replacing, reducing and refining the use of animals in biomedical research. Here we go, non-animal models like in vitro and in silico is what they're looking, particularly in the field of breast cancer research, because they've really hit a wall with animal research. Is that something that the government has considered or will consider in the future?
Look, I think it's fair to say that if we could do efficacious research with appropriate outcomes for human beings, without involving animals, I think everybody would be very keen on that. But the researchers themselves are the ones who would best know that. I know recently insects are animals. Well, yeah, they're animals.
Yeah.
But recently there was some discussions I was having with some people about the use of vectors from cells from insects as opposed to other vectors that might be available for dealing with cancer and COVID research and so on. So I think everybody's conscious of it and generally keen to avoid using animals if at all possible, but not always possible.
Yeah, it's interesting. In the EU, they've actually made a commitment to phase out the use of in the EU. They've made a commitment to actually phase out the use of animals, and there's no definite timeline at this point, but working towards that. We've also previously spoken about the primate breeding facility in Western New South Wales, and in previous budget estimates, you advised me that the funding from the National Health and Medical Research Council had actually ceased for that breeding facility, and that Sydney Local Health District had taken over actually funding for that facility. Has the funding for the baboon facility continued from Sydney Local Health District? And is there a plan to continue funding it going into the future?
My understanding is that the funding has continued and the baboons are living a rather relaxed life and a happy life, one that we all look forward to, getting closer for some of us.
I don't think that people want to be experimented on. I don't think that's a life that people would be wanting to be looking forward to.
I think they're actually... Look, I'll find out for you and I'll let you know. When you come up to see me in a couple of weeks, up the office, I'll tell you.
Thank you. Could you also take on notice, if you don't mind, how much funding they've actually received in the period of 2019 to 2020 and 2020 to 2021?
Specifically, sorry, for
Specifically, so the primate breeding facility in Western New South Wales.
Western Sydney?
Western Sydney. How much funding they've received from 2019 to 2020 and 2020 to 2021 from the Sydney Local Health District?
No problem.
Thank you. Are you aware if this facility is the recipient of any other further funding from the New South Wales Government via grant programs, for example?
I don't know, but I can ask the same thing from Sydney Local Health District. But I'd imagine if it's coming through Sydney Local Health District, that would be the prime source of the funds, is what I would expect. But it may be that they get money from other sources and it comes through the Sydney Local Health District. But again, I'll let you know. I'll take that as a question on notice and get a formal answer for
Wonderful, thank you. And if you are taking that one on notice, would you mind also taking it on notice to find out how much that they might be receiving from other grant programs, if that's available?
Absolutely.
Thank you. Each year, the national not-for-profit Jean Hales conducts a survey of Australian women's health. And in the previous 2 years, 16% of women surveyed reported discrimination in accessing healthcare. Is healthcare discrimination an issue that's been raised with your office? And is it something that the government is trying to address?
I think, no, it hasn't been raised with me. Mm-hmm. I think that generally the health services, at least through the state health services, are very, very responsive to women's needs and try to be as effective as possible in that. That report that you're talking about might have covered, for example, GPs or specialists or others. I
think it's quite broad. It's actually interviewing 9,000 to 10,000 women every year, and it's essentially a survey in regards to what they've had experience through the healthcare system
so I don't
generally.
Get accused of mansplaining. Can I actually hand this to one of the ladies on either side of me who might know
Yes.
something about that?
I'm not familiar with the review, but happy to take it on notice, actually have a look at it and then see how it's relevant to the New South Wales Health setting.
I mean, if you can give us the details, perhaps text me afterwards with the details, I'll get a copy of the report because I'm interested to see just what areas they've highlighted. If that's the case, then we'll do whatever we can to try and address it, but I wasn't aware of that.
Fantastic, thank you for that. Just to sort of alert you as well, one of the areas that they're talking about particularly is women living with a disability, and women also within and people within the LGBTQI community have reported that they feel like there are higher rates of discrimination, and that they also have poorer health outcomes compared to their peers.
I think that's actually a slightly different issue because certainly I've had talks with the disability groups.
Mm-hmm.
And yes, let's address that for a second, and not just women, but men and women. I think that from what I've been advised that certainly there is a feeling, a belief that, for example, general practitioners aren't always necessarily sensitive to the issues of people with disabilities, and they might have, and others for that matter. I shouldn't pick on GPs, but anybody might end up in the health service having a predetermined view on what should or shouldn't happen, and I think that's not acceptable. And as to the LGBTIQ community, I think that's also, I've had certainly Nick Parkhill and others from ACON have raised that with me, which is one of the reasons why I have supported funding of a service for that community. And I think we're at the stage where we've worked on it. I've worked on it with them for the last couple of years, and last I heard we're only about $1 million short, and they're trying to get that money from the federal government. But I'm also looking, if they don't get that, I might look at other funding sources to establish a centre that's in Sydney. I mean, a lot of people who are LGBTIQ go to GPs, go to just the usual hospital facilities, but some don't feel comfortable in sharing the details with the GP or with the health community, and that was the argument that Nick and the others from ACON have put up. And I think it's a reasonable argument from what I've heard from, friends who are in that situation. So I've certainly indicated that the government would like to support having a separate centre, and we're working on that at the moment. Hopefully we'll get that kicked off sooner rather than later, in the sense of get the final funds there and get it built. Early on there was some issues because, just trying to remember now, I think there was...
Nigel was taking the lead on that one, Minister,
was he?
if you wanted an update.
I'll just say this, I think there was it was in a West Council, I think, that it indicated they might have some land or some location available. And then there were some issues that went on, and I don't know where it got up to, but I know that we're well and truly moving to it. Nigel, can you help us with this, please, wherever you are?
Dr. Lyon.
So I think most of those issues you outlined have been sorted through. So there was initially an issue around co-location in a council building in the inner west, and I think both us and ACON are agreed now that there will be an alternate arrangement for the physical facility once we finalise the funding. As you outlined, we're almost there in terms of the funding. I think there's just a shortfall in terms of the operating costs that's proposed for the service and what's available.
What's the operating costs? I thought it was the capital.
So that's where we're at the moment.
Oh. Thank you.
Great, thank you for that. And I'll definitely send that report on to you as well. The New South Wales, just going back, we were talking a little bit about dementia before we went on the break. The New South Wales Ageing Well Action Plan outlines that you are partnering with the Australian Government to implement the Commonwealth Specialist Dementia Care Program. Can you give us a little bit of detail about what is involved in that program and any timeline for its implementation?
I'm going to ask Nigel again to answer that, if that's all right. Nigel, could you respond to that, please?
I might take the specifics about the program on notice, but indicate that we are doing a range of work in relation to dementia care and in partnering with other organisations, including non-government organisations, in providing funding to support dementia care. It is a key area of focus for our aged care services. Our specialist aged care services have particular services that specialise in support for people with dementia and ageing related cognitive dysfunction. So it is a very important focus area for all of our aged care services. But we do have specific funding that goes through to organisations like Dementia Australia. They receive funding for statewide support groups for carers and people living with dementia. So we provide around about $260,000 per annum through to Dementia Australia. And we also provide support through other organisations such as United Church of Australia for dementia daycare programs. So there's a range of non-government organisations that have delivered support and funding from our services. And we have a lot of work that's going on in response to the findings of the Royal Commission, as you probably are aware, which highlighted the issues around cognitive disability and people living with dementia and intellectual disability. We've made significant investments into those areas as well. So it is a major focus of our services. We have a range of initiatives in place. I'll take the specifics around that particular program you're talking about. We can add those in relation to a question on notice around that one.
Great, thank you.
Thanks, Dr. Lyons. Kay Femin.
Thanks, Chair. Just wanted to go back to regional health and back to the Murrumbidgee Local Health District. We were talking earlier about Leeton Hospital. I understand Leeton, Hay, Hillston and Deniliquin do not employ a regular doctor on site at those hospitals. Lots of people presenting to the emergency department at those hospitals are being turned away because there's no doctor there to treat them, and they're sometimes being sent to bigger base hospitals. So I just wanted to talk about Griffith as one of the potentially, slightly bigger base hospitals. But currently, Griffith has no orthopaedic or mental health services. And I just wanted to check, Minister, that you're aware of these, the kind of numbers that of patients that are being transferred. So from Griffith Base Hospital to Wagga Base Hospital, there were 1,268 patient transfers that occurred. This is between 2015 and May 2021. In the same period, there were 882 transfers for mental health care. So that's a significant number of people being transferred each year from transferred during that time from Griffith to Wagga. Would you agree?
With what aspect, sorry, of your question?
That it's a significant number of patients that are being transferred.
5 years, over 5 years?
Over what period?
Yeah, 5.
If it's necessary to transfer patients, then obviously what I would say is it's necessary to transfer the patients. In regional areas right across Australia, and as I said earlier, in other parts of the world, you simply cannot get some specialists into some areas. And so you've highlighted 4 hospitals. I know of a number more than that outside that particular local health district where it has proved impossible to get specialists. But, it's not just in those areas, Kate. I mean, I remember down on the Northern Beaches, I wanted, as a local member on the Northern Beaches, we wanted an ICU, an intensivist, to work at Mona Vale Hospital. Mona Vale Hospital, compared to Griffith, a bit bigger than the $200 million redevelopment of Griffith, but similar. And we could not, for love or money, they advertised all across the world, get an intensivist. And the reasons were that there wasn't the patient numbers in intubated beds in that hospital to actually attract someone with those skill sets. You have to attract the people through a variety of measures, but one of them is to have the core patients to be able to keep up the skill sets. And if you don't, they won't come.
So $200 million then on Griffith Base Hospital, you said the newly
Off the
developed...
top of my head, it's about $200 million being spent on the new Griffith Hospital. It also sits on the same campus as the St Vincent's Private, so there's a bit of shared work there with the St Vincent's Private.
Sure, but one of the issues is, I think, with Griffith is that ideally orthopaedic services will be provided and ideally mental health services will be provided, but they're not being provided at the moment. And do you know whether that's because the staff can't be found? Because, again, people are being transferred to get bones set to Wagga and also for mental health services to Wagga.
In the good old days, GPs would, of course, do basic sets of non-compound fractures, for example. Very rarely happens now. Done with a more specialised service, and it's sometimes multidisciplinary as well. But look, I'll ask Dr. Lyons, who I'm sure is bursting at the seams, wanting to answer this question.
Great.
Dr. Lyons, would you like to enhance the knowledge of all of us, please, on that issue?
Thanks, Dr. Lyons.
Thanks, Minister. So there has been ongoing advocacy for improvement in mental health services in the Griffith community, as you're probably aware. And with the redevelopment of the Griffith Hospital that the Minister outlined, there has now been provision made for a 4-bed psychiatric emergency care facility to be implemented there to enable on-site admission for people rather than transfer through to Wagga as the only path of action if someone's concerned about somebody's mental health status. So the aim of that would be to ensure that we have the mental health team enhanced in Griffith to enable the care on site of people who've got short stay conditions. It won't be for longer admissions, those will still need to be transferred through. But the idea is that for a short stay admission, then they will be able to be cared for within the 4-bed psychiatric emergency care facility in Griffith Base.
Okay, and sorry, Kate, can I just add, so what Dr. Lyon is saying is that in the redevelopment there will be a mental health service, but it'll be a short stay one, because obviously that's a little simpler to deal with for people who might need some acute care. But there'll also be a new orthopaedic service as well, which Dr. Lyons didn't address as part of the redevelopment.
Yeah, so that's 4 beds. That's not a kind of separate funded mental health ward. When you're saying kind of short-term kind of acuity stay, is there a kind of time on that generally, Dr. Lyons?
So they would normally be admissions that would be a matter of days, not a matter of weeks. And they are separately identified. We have that psychiatric emergency care model in a number of our hospitals around the state, in addition to acute mental health units that are in patient stay for longer periods. They are a specific model under the mental health service provision, and they are specifically designated as such.
Okay, thank you.
Can I just add,
yeah,
so
sure.
people aren't under any disillusion?
Under any illusion.
Whatever, thank you. Down at that hospital, I would expect that whilst it's a bit like the discussion we had earlier on today, build it and sometimes they won't come. So we're going to build it, we're going to provide it, but I doubt that we'll be able to get, I doubt we'll be able to get a psychiatrist there to do the service that's necessary. I think that there's such a lack of psychiatrists, in every subspecialty of psychiatry, including paediatric psychiatry, that we will actually be able to get somebody there. What I anticipate is that there'll be nurses with mental health training, hopefully available, and they will have to rely on the advice probably from a major hospital like Wagga Wagga Base Hospital.
Okay.
And if the patient can't be managed just in those first, probably, I mean, Dr. Lyons said days. I'd say usually from my experience, and it's only after 5 years, so I could be wrong, but usually in those sort of units, they might last there for 3 days, tops 3 or 4 days. And then if it can't be managed, the person would generally be transferred to a facility because it's going to need much longer term care.
Yeah, thank you.
Correct, Minister. It's usually about 72 hours stay in the psychiatric emergency care facilities, and then if needing that transfer, that would occur after the 72 hours.
Yeah, okay.
Thank you.
Thank you. I'll pursue that a bit more tomorrow in mental health. Minister, during one of the Public Accountability Committee hearings a few months ago now, it was kind of revealed or came to light that you and Dr. Kerry Chant had not met with some of the representatives of Aboriginal medical services. I just wanted to check whether that has been rectified, whether you have consulted with...
I know. I
remember that?
I have a recollection that seemed to be the outcome, but I mean, I have met with representatives from, I think it was the Aboriginal medical services community have very different aggregations of interest and don't necessarily all get on each with the other. And certainly from my point of view, I've met with, only recently, or a couple of months ago, 2 or 3 months ago, I met with AMSs in a number of different towns. And so I'm not quite sure that's an accurate reflection, but anyway.
So
what's the question though?
Yeah, so I just wanted to know whether you had. So this was Dr. Peter Malouf, who is the head of the Aboriginal Health and Medical Research Council of New South Wales, which is essentially the peak body for Aboriginal health organisations, and he said that he hadn't met with you or Dr. Kerry Chant. Like clearly, like with a lot of different health organisations, there are lots of organisations, but there are peak bodies. But there are peak
different
bodies.
Aboriginal medical services, and some of them.
This is a peak body, though, Minister.
Yeah, look, I don't think I've met with that gentleman recently at all in the last 12 months, but I've certainly...
In fact, one of the Indigenous reporters for the Sydney Morning Herald says it's the state's top Indigenous health body. That's how he has pitched the New South Wales Aboriginal Health and Medical Research Council. So... Just want
I can confirm, if I may, I met with them.
Okay, I was about to. Thank you, Ms. Koff. I was about to say, within your executive, has that happened?
Yes, I certainly did. I met with them on the 26th of August. We did it virtually because we were in restrictions, and it was the chief executive and Dr. Malouf in conjunction with our manager of Aboriginal Health Services, and we discussed at length the vaccination rollout. Because at that stage we had the conversation that we need to work in partnership, the state with the AMSs, to get the rollout to the Aboriginal community and take some responsibility of ourselves rather than be reliant on others.
Let me say, regardless, the AMSs have been amazing across the state, reaching out particularly, well, everywhere actually in the regional communities, but also even in the metropolitan areas. So I think some of them, I think of the one up at Walgett, that's done an amazing job. The one in Dubbo, generally they've been incredible. And a lot of their nursing staff have been the ones that have gone out working with the local health district, Aboriginal staff, to actually knock on those doors that I referred to, I think about 10 o'clock this morning. Knocking on doors and convincing people to don't listen to the social media but listen to the medical advice and get vaccinated. And that's why, as Ms Pearce has said earlier today, why our rates are so high.
Thank you, Minister. What's that called?
Thank you.
Sorry, the rates of vaccination in the Aboriginal communities are so high.
Thank you. Minister, I want to take you to the voluntary assisted dying bill that's before the Parliament. And I want to take you to an email that was sent out on October the 20th. And
By whom, sorry?
By Alex Greenwich. And the email says, and I quote, New South Wales Health has assessed the bill and will be able to address how it will operate, how it compares to other states, and any concerns members may raise. Now, I'm on the record that I do not support the framework of the bill, but I support a number of other, a woman's right to choice. But
what?
A woman's right to choice and on choice issues and that. But when it comes to
a woman's right to choice, what, for death? What? I don't know.
No. Minister, I was just giving you a framework to say that I have concerns about the bill. So I want to know in this email, so what's the relationship with New South Wales Health and the bill?
None.
Why is New South Wales Health, quoting here, providing an assessment of the bill and how it will operate and how it compares to other states?
Just as if you asked me to have New South Wales Health give their commentary or give advice on particular issues, whatever you wanted to raise, then almost certainly, as I know anything you would ask Mr. Secoul to be reasonable, I would ask the Health Chief Executive whether there were people within New South Wales Health, there usually are experts in New South Wales Health.
So any member of Parliament can unveil... Okay, go ahead.
That would be able to give advice. And I think we actually had wasn't there a day, I think there's already been a day in here, because I went for the last hour and I think that was, weren't there New South Wales Health officials at that? I can't remember. There were. I think it was in just and I think Alex Greenwich actually asked whether there were some people who had knowledge of the issues and whether they would come and talk to members of Parliament. I must say I only got there late because of the ministerial obligations, and I'm not sure how many members of Parliament were there earlier in the afternoon.
But you're missing my point of my question. My point of... So, in fact, can any member...
But it was a for and again. It wasn't one way or the other.
I was going to get to that. So, can any member of Parliament avail themselves upon New South Wales Health to provide an assessment or how something would operate? Is that something that's available to all
in a health
members?
context?
Well, no, in any context. It says here that New South Wales Health has assessed the bill and we'll be able to address how it will operate and how it compares
Was
to other
that
states.
before the actual day they had him?
Well, it was the day of when he's calling for people to
Oh
attend.
yeah, well they did. There were people talking the pros and cons.
So, just to be clear, Minister, Mr. Greenwich approached you to provide that briefing, and you sought that advice from New South Wales Health.
If it wasn't you, then who authorised
I don't remember whether he came to me or to Health. He certainly talked to me, as he has to you, no doubt. He's talked to everybody, I think.
No, he hasn't. He hasn't talked to me.
Maybe he knows you're not supporting it.
Maybe he does. Maybe he does.
But, yeah, look, what's the problem with that? That New South Wales Health's a government agency. If you want to go and sit and talk with a doctor, I'll organise a doctor to talk to you. I mean,
So you'd avail this upon any member of Parliament would be able to do this?
Of course.
Oh, okay.
Just to be clear, New South Wales Health hasn't taken a position on whether they support or oppose the bill?
No, not to my knowledge. There are people, I think, who have analysed it, and obviously I had a briefing from them, and in that they indicated comparisons to other states and territories, the sort of things you give a minister, but they weren't saying they support it or they don't.
And just to be clear, you commissioned this or this, perhaps you can provide on notice how the actual process started. How was this actually
Well, it sounds like he's actually asked me or Health. I don't remember now which it was, but does it matter?
That's what we're trying to
maybe
find
Dr. Koff. Dr. Koff, could you assist with
She's not doctor, she's...
Oh, sorry. Ms. Koff.
Ms.
Ms. Koff.
Actually, Mrs.
Okay. Ms. Koff, can you assist? Can you assist? Well, does New South Wales Health have a position on the Alex Greenwich bill?
No, New South Wales does not have a position, nor should it have a position on that. And what we asked, when could we assist in explaining some of the issues around it, to provide a cross-section of clinicians just to be able to assist in questions. So Professor David Currow, Professor Catherine Clark and Dr Frank Brennan, I understand, all turned up to answer questions. Because the main issue from my perspective and what we agreed is people need to make an informed decision if they're having a conscience vote, and if we can assist in any way to let someone make an informed decision for a conscience vote.
And we did talk about that. I did agree with that, and I said whatever is necessary to inform people of what the ins and outs are of this, what the pros and cons, what the challenges are, what the technical aspects are. Well, yes, of course.
Can I just ask, in regards to the casting out of the offer for people from New South Wales Health to be available, there's a process in doing that. You mentioned, Ms. Koff, there was 3. How was that done?
I contacted through our clinical teams as to which clinicians might be available and willing to have conversations about the issue.
I think Professor David Currow would have been a logical choice, though, Mr. Chairman, because he, for quite a number of years, I think since I became minister anyway, he's headed up the Cancer Institute, and I think he advised the British MPs of the the fors and againsts of the whole process. Is that right in the UK?
And he's a palliative care physician by training.
Can I ask one final question? Secretary, in 2019, the federal government told Bega and Eurobodalla it would be eligible to apply for a targeted but competitive grant round for regional radiation treatment centres, but Southern New South Wales LHD didn't apply. Are you aware of why they didn't apply?
No, I'm not. I'll take that on notice.
Okay, thanks very much.
I don't either. First time I've heard that one. Don't know.
Emma.
I think our time has expired.
Yes. So Emma doesn't have further questions.
Yeah, no,
okay.
I'm done too.
Oh, okay.
Now that we know we've got this early minute, it's like, no.
Yay!
I could have gone for hours though, but
of course we all could have. But can I thank you, Mr. Chairman, and the committee?
Hang on. Not a moving game here. We agreed for an hour, and you recall I said we kicked off at about 3 minutes past 3. That's what happened. So
if you want to keep us here, I'll stay here.
I'm not being a pedant, but we sort of agreed to a position. So
but I think they've just said they don't need any more. But if they want more,
let's just.
Well, I have a couple quick questions, Mr. Chair, about Rouse Hill Hospital.
We can't just keep changing on the run. So let's go through to the completed time, and then we can all go.
Whatever you want's fine by us.
Rouse Hill Hospital, Minister. I'll be very quick, Courtney. Sorry. What level of emergency department will Rouse Hill Hospital have?
I don't know. I can't remember.
Can you take it on notice, please?
Sure.
Okay.
Minister, in March.
You know the block of land. Sorry, Courtney. You know the block of land change.
You took it on notice. So go to Courtney.
Okay, sorry, Courtney.
Minister, in March, I asked you about the progress of the salary packaging issue for health staff, which means that they don't receive the full benefit of the.
There was that federal thing because I know Gerard Hayes from the HSU had raised it.
Yes, that's right. Can you update the committee on the progress of that?
Can I ask Phil Minns, where is he still there? Yes, Phil, could you answer that, please?
Mr. Minns.
Speaking. We've had some, I guess, initial conversations with the Health Services Union, but from our perspective, the arrangement whereby benefits of salary sacrificing are shared stems from a bargaining process back in the early 2000s, where there was a commitment to use that mechanism as a device to fund wage increases, which were in excess of 4% a year over 4 years, from my memory. I might need to provide an answer on notice to be exact about that. There was a significant 4-year wage bargain, and the position of government, as I understand it, was that they were not going to supplement the health budget in the second and ongoing years. So it became necessary to look for savings measures to be able to fund the agreed wage position. And so that's where the arrangement comes from. And the consequence of changing that arrangement now would be that New South Wales Health would have a budget issue in the order of, I think it's $280 million per annum. And we'd also probably have to navigate the current position of the government on through the Wages Policy Task Force, which is pretty stringent in the arrangement.
Sorry, Mr. Minns, we're just running out of time. So can I just ask you one quick question? You said that it's $280 million a year. Is that how much that the government receives from this?
Well, that's half of the benefits.
Yes, I understand. Yeah, and I'm familiar with the history of the policy and where it's come from. I'm just interested in knowing that's how much. That's half of the value. That's the value that the New South Wales government gets from the arrangement. Is that correct?
It's in that order.
Okay.
If it's a slightly different number, I'll come back to you on those.
I appreciate that. Thanks, Mr. Minns.
Okay.
Thanks, Mr. Minns.
Yes, Minister, in November, obstetricians at Blacktown Hospital threatened to resign because of safety concerns. What's the status of obstetrics at Blacktown Hospital now?
They all withdrew that notice.
Yep.
And Mr. Loy's on the phone, but basically Graham Loy worked through those issues with them. I think that, there were some. I agreed that there should have been concerns there. The relationship. The approach was not as good as I would have liked it to have been. Mr. Loy, do you want to add anything to where that's up to?
Yeah, thanks, Minister. So we sat down with the teams through that. They quite rightly pointed out some areas. They had some concerns within the obstetric services. We looked again at the structures of the FTE profile that was there. We added an additional 3.5 FTE of senior consultants in. We added an extra 15 FTE of midwives and nurses into maternity services. We've done a subsequent birth rate flagged, another 13 that we are in the process of recruiting to add into that. We added in a dedicated emergency Caesar theatre and staffed and funded that. And we added in additional outpatient clinics to support the gynecology service. And so they are all either complete or but complete. Predominantly the 13 FTE from the outstanding piece, and we have just signed off on the tender for a real-time
new director of obstetrics at
institutions to be able to see from their phone at home. So we removed that technical interface between which is the section of the CTD tracer. When I look at, they can see the whole history for every patient. So it's progressed significantly. New head of department, and it is working incredibly well at the moment. So the latest feedback has been very strong.
That was an answer.
Thank you very much.
Thank you. That's it for me, Greg.
Yeah, we can.
Yeah.
Okay, you got 2 minutes, but no. Okay, so they've cut themselves short. So that's okay. No, only joking. Can I just take this opportunity, Minister, thank you very much and all the officers for coming along. We know how exceedingly busy you are all the time, but certainly in the particular context of what we've been facing over the last well over 12 months. And can I just take the opportunity also on behalf of the committee to extend our thanks through yourselves to Dr. Chant, who is otherwise detained this afternoon on another matter. And importantly, to everyone inside New South Wales Health who have worked tirelessly, selflessly over this long period of time, over difficult circumstances, to keep the citizens of New South Wales safe and well. And we sincerely appreciate that very much.
Thank you. And on behalf of the health staff, I'm sure they've all done their very best. So thank you to the committee for acknowledging that. They have really worked incredibly hard. This has been unprecedented for 2 years. It has been actually gruelling and horrible, but they've actually faced up to it and they've kept showing up at work, doing their job despite all of the dangers to themselves. So I think it is worthy of acknowledging that incredible contribution. Thank you.
Thank you. Thank you very much.
Thanks to all the team on the line too.
And thank you everyone who's joined us remotely
today.
today. We appreciate you doing that. Thank you very much.
Thanks, guys.
That brings our session this afternoon to conclusion. Thank you.
Thank you.
Thank you.
And we don't have any documents.